fact, even the Supreme Court has taken cognizance of this. हर वर्ष उच्च न्यायालय में एक गोष्ठी होती है. In fact, September 28th, 29th is this year's Supreme Court consultation. I will be in Delhi then. This year, the focus is entirely on JJ Act and children with disability. But last year, in fact, even the address of the Honorable Chief Justice, he had essentially spoken almost entirely on the Vidhi report and basically made a case for not criminalizing consenting adolescent relationships. So as the Adolescent Health Academy, I think the point that you're raising is very relevant, and that's where your role in advocacy comes in. If two people, they may be 17, they may be 17 and one may be 17, one may be 19, so there is a age of difference exception, which is often made when you apply POCSO. So, Jay, I have noted, I tend to lapse into Hindi. In fact, I'm Tamilian, actually. I'm not even Hindi speaking. I speak Tamil.
I'm really amazed.
No, Jay, don't.
आप तो बिल्कुल हमारे यूपी वाले हिंदी बोल रहे हैं, तो इतनी अच्छी हो रहा है.
No, Jay, don't worry at all. The entire presentation after 11 will be in English.
Yes,
so the point I was making is that even the Supreme Court has taken cognizance of the fact that consenting adolescent relationships should not be criminalized. And I think as thinking members of the Adolescent Health Academy of IAP, part of the advocacy role that the Academy can play is also to constantly within your community discuss the issue of how do you function as an advocate for two adolescents who are genuinely, deeply and respectfully in love with each other. There is no coercion, but it's just fear of perhaps because of class or religious or social differences. And how much do you how much of a social advocacy will the Adolescent Health Academy play in essentially to preserve reproductive rights and reproductive health issues. So iska bhi, we have a frame of reference. We call it the happy, healthy, safe and responsible approach to sexuality. And we have a window approach to this, which is there in the Samvad website. Some of the links Preeti has already sent of our life skills program for adolescents, particularly the manual on gender, sexuality and relationships. In that, we have given a very nice detail of how you go window by window. But the point is, as an academy, can you take a policy decision? You guys speak so much about social pediatrics. And if we extend the same paradigm to social advocacy as far as reproductive rights and sexuality rights of adolescents are concerned, given the frame of reference of safe, happy, healthy, safe, and responsible sexual decision-making, these are some of the ideas that the Academy could explore going ahead as part of its mandate. Let me not take too much of time, I think.
And MKC sir, आपके सेशन के बाद ना कुछ ऐसे important tips दीजिएगा जो teenagers, whether they are into drugs or whether they are into relationships or something, whatever the things which are not socially acceptable as per parents, but nowadays they have become quite acceptable, like especially relationships. तो तब हम parents की कैसे counseling करें, practical tips वो अपने talk में जरूर add कीजिएगा sir. So I think now we can start, Shilpa.
Unfortunately, there were two demands on me, one on family therapy, one on parent counseling. I decided to venture into an area which we have never discussed, that is family therapy. Not that I am an expert in that, but still we can delve into it. So
you are experts, sir.
Maybe I may not cover whole parent counseling that much.
But छोटे से tips जरूर दीजिएगा सर, क्योंकि these are very important things.
Okay.
जहाँ हम parents को handle करें, क्या this is their form, जहाँ हमको वो करना है. Shilpa?
Yes, ma'am.
Yeah.
Shall we start, ma'am?
Yes, we can start.
It's 10:30.
I think.
Yeah.
So a very good morning and very warm welcome to all the esteemed members, distinguished guests, and galaxy of intellects present here. It is my honor to extend a heartfelt welcome to all of you for the grand finale of the e-webinar series, Adolescent Counseling and Basics Beyond. Today marks a significant moment as we conclude this enlightening series with a comprehensive full-day training session. And we are privileged to have with us two internationally renowned speakers who will guide us through the intricacies of parental counseling and trauma-informed care for children and adolescents. On behalf of Chhattisgarh AHA, I welcome you all the respected participants, and this series, Adolescent Counseling in Office Practice, is very well proposed, designed and advised by Dr. MKC Nair sir, Dr. Preeti Galgali ma'am and Dr. Kavita Meghani ma'am. Through this series, as we gather and gain the knowledge of and skills delivered by the ingenious, extraordinary masters of this field, so that at that we are able to explore the art and science of adolescent counseling. Before we begin, it is my honor to welcome our guest of honor, whose presence greatly enriches this session, Dr. Basavaraja sir. He will join us briefly. President, Central IAP, and he is the senior consultant pediatrician, and we all know him very well, whose contribution to pediatric care have been inspirational. And Dr. Onkar Khanwal sir, head of the department, Pandit JNM Medical College, Raipur, and senior consultant pediatrician known for his vast experience and dedication towards the pediatrics. Along with that, I would like to welcome all the senior members, Dr. A.T. Dapke sir, Dr. Ashok Mehta sir, Executive Board Member, Dr. Sanjay Agrawal sir, Dr. Mudliar, and all the office bearers of Central IAP, CHA, and CG IAP on and off the webinar dais. So moderating today's session, we have three esteemed chairpersons who are highly respected in the pediatric community, Dr. Sanjay Agrawal sir, Dr. Harish Naik sir, and Dr. Pooja Dupe ma'am. I would like to welcome all the three respected chairpersons for the session today, and we are pleased to have them as chairperson for today's webinar. With the equal pleasure, I would like to welcome the team of Central IAP, the members in the guidance of Dr. G.V. Basavaraja sir, respected Geeta Patil ma'am, Chairperson Central AHA 2024, and her enterprising team, and Honorable Dr. Ashok Mehta sir, Executive Board Member Central IAP, distinguished Dr. Kiran Makhija sir, President CJ IAP 2024, and his just full team. And we have two very renowned personalities with us today as our guest speakers, Dr. MKC Nair sir and Dr. Seshadri sir. I would like to welcome both of them. And with this, I would like to request Dr. Sanjay Agrawal sir, our chairperson for the today's session, as the first session.
Shilpa, Dr. Khandwal sir is there, guest of honor.
Sir has joined, ma'am. Actually,
yeah.
Sorry. So I would like to request Dr. Onkar Khanwal sir to share his thoughts and initiate this webinar. Sir.
Onkar sir?
Ma'am, I have not seen him actually.
No, he said I'm joining. Just 1 minute, wait.
Okay.
Wait for a minute, Shilpa.
Sure, ma'am.
Basavaraja sir may join any time, so then he'll let us know.
மரபணு மாற்றப்பட்டவை 5 இருந்தால் ஆர்கானிக் தான்
Ma'am, Khanwal sir is joining right now.
Yeah, he's joining. He said, I'm joining.
Okay.
Khanwal sir, are you there? He's joining from mobile actually. Maybe there's network issue. Khanwal sir? Should we start or what? He said,
Yes.
I'm joining.
Yes, he has joined now. I welcome Dr. Onkar Khanwal sir, Head of the Department of Pediatrics, Pandit JNM Medical College, and he is a senior pediatrician. I would like to request Khanwal sir to say a few words for the.
Thank you so much, Shilpa. It's a privilege to be amongst all these elite academicians of Adolescent Academy of Pediatrics, and definitely they have been doing a very good work handling the problems of adolescents of our country, of our state, and kudos to them, and keep up the good work. Thank you so much for uh, keeping with you. Thank you so much.
Thank you,
Kindly go
sir.
ahead.
Thank you.
Thank you, sir, for your wishes. And with this, we are moving ahead. So it's my distinct honor to introduce our first chairperson for today's session, Dr. Sanjay Agrawal, sir. He is Senior Consultant and Director, Agrawal Hospital, Mungeli, ex-BMO Government Hospital, Mungeli. He has received as Best Award winner of IAP CG 204 as Best Ruler Pediatrician. He is past editor of IAP CG Bulletin, past president IAP CG 2010, ex-director and vice president JC International MP, founder president JC Higher Secondary Public School Mungeli, and he is an adolescent counselor at his own school, as well as he has done many social activities for the adolescent counseling and awareness programs. And what I like about the sir is most he is a wonderful and fabulous painter. He is doing the canvas oil painting, and I have seen his work in person. It is absolutely fabulous. So I would like to welcome sir to say a few words to the gathering and introduce our first speaker, Dr. MKC sir. So please unmute yourself.
Audio is not working.
Sir, it's audible now.
Okay. Thank you, Shilpa. Thank you, Kavita, for so nice introduction. Thanks a lot to CGHA. I welcome all dignitaries of national and international repute on behalf of CGHA. I admire the hard work of CGHA members. मध्य प्रदेश में शेखपुरा जिले में एक रेलवे स्टेशन है जिसका नाम है MKC। वहाँ बहुत सारे लोग उतरते हैं, हजारों लोगों ने वहाँ पर शरण ली है, लाखों लोग वहाँ रुके हैं और कितनों को इनने अपनी सेवा दी है। वैसे ही हैं हमारे MKC नायर सर। ये एक ऐसा नाम है जिसने लाखों करोड़ों बच्चों को अपने प्रयास से नई जिंदगी दी है और उनके माता पिता को एक खुशी, उनके एक मुस्कान दिया हुआ है। आज का यह दिन मेरे लिए बहुत सौभाग्य का दिन है क्योंकि मैं आज उस शख्स का परिचय देने जा रहा हूं जिनकी उपलब्धियों को शब्दों में बांधकर बयान नहीं किया जा सकता। डॉक्टर नायर इस वेबिनार के प्रणेता भी हैं, जिसने छत्तीसगढ़ एडोलेसेंट चैप्टर को एक नया आयाम दिया है। MKC सर को उनके 25 साल के लो बर्थ वेट बेबीज के लगातार फॉलोअप के लिए केरला यूनिवर्सिटी ने डॉक्टर ऑफ मेडिसिन की उपाधि दी है, जो किसी भी मेडिकल पर्सन को पिछले 80 सालों में देने वाली यह पहली उपाधि थी। फेलो ऑफ द नेशनल एकेडमी ऑफ मेडिकल साइंसेस के लिए 2020 में इन्हें चुना गया। ये नूरुल इस्लाम सेंटर ऑफ हायर एजुकेशन में बोर्ड ऑफ मेंबर हैं। नेशनल इंस्टीट्यूट ऑफ फिजिकल मेडिसिन एंड रिहेबिलिटेशन त्रिशूर में बोर्ड ऑफ मेंबर है। नेशनल इंस्टीट्यूट ऑफ स्पीच हियरिंग एंड तिरुवनंतपुरम केरला इंस्टीट्यूट ऑफ मेडिकल हेल्थ मैनेजमेंट हेल्थ एंड रिसर्च सेंटर बेंगलोर, ऐसे अनेक नाम हैं। और इनका एक विशेष रूप है ना, वो साइंटिफिक एडवाइजरी कमिटी के रूप में डेलव्यू कॉलेज ऑफ फार्मेसी के एकेडमी मेंटोर भी हैं। इनके 210 नेशनल और इंटरनेशनल पब्लिकेशन हैं और इन्होंने 29 मेडिकल बुक में अपने आप को ऑथर और एडिटर के रूप में प्रूफ किया है। त्रिवेंद्रम डेवलपमेंट स्कीम चार्ट के प्रणेता है, जो कि राष्ट्रीय बाल स्वास्थ्य कार्यक्रम का बैकबोन है। वर्तमान में केरला यूनिवर्सिटी ऑफ हेल्थ साइंसेज के वाइस चांसलर हैं। इन्होंने पीएचडी, मास्टर ऑफ मेडिसिन ऑस्ट्रेलिया, एमबीए, एमए फिलॉसफी, एमए, एमसीएनजे, एफएनटीएफ, एफआईएपी, एफएमएस अनेक डिग्रियां ली हैं। मैं इनके उज्जवल भविष्य की कामना करता हूं और साथ ही छत्तीसगढ़ एकेडमी को साधुवाद देता हूं कि इन्होंने इतनी बड़ी हस्ती को आज इतने दिनों से, जून से लेके अभी तक सितंबर तक बांधे रखा। मैडम गलगली, मैडम हिमा बिंदु और बहुत सारे ऐसे लोग हैं जिन्होंने समय समय पर छत्तीसगढ़ एचए का मान आगे किया है। मैं उज्जवल भविष्य की इनकी कामना करते हुए शिल्पा को फिर से स्टेज देता हूँ। थैंक यू।
Thank you, sir. May I invite Dr. MKC Nair, sir, to start his session?
Okay, I'll do the sharing now.
Sure, sir.
Sorry. Okay, 10:45. I'll finish by 11:15.
Okay, sir.
Yeah. Basically, the reason why we thought of family therapy, because all the topic POSCO and all that, what Shekhar is going to talk there, there's a huge element of family therapy. For example, Madam asked, Kavita said some questions. And for all that, how to communicate, how to tell parents. We do a lot of things, but parents run away, where some elements of family therapy may be required. That's why I thought I'll focus on this today. Now, first of all, we should know what is a family. Family is the smallest unit of world civilization in the world. Any area, civilization started from a smallest unit of family. It's a group of people related either by consanguinity or affinity through marriage. The families offer 3 words you must remember: predictability of behavior, structure, and safety to the members. Predictability, structure, and safety. And most human societies use family as a primary purpose of attachment, nurturance, and socialization. 3 things: attachment between people, nurturing people in the family or children in the family, and socialization. Now, these 3 words are important: attachment, nurturance, and socialization. Then anthropologists, of course, classify as matrifocal, mother and her children. Patrifocal means father and her children. conjugal or nuclear means married couple with children, or extended with grandparents, uncles, cousins, and all that. Okay. Now, most important, two words in family therapy is there. One is called the boundaries. The other one is called the power structure. Everything, family therapy is based basically on these two aspects. And most important, the power structure. Let's look at what is family boundaries. Boundaries in the family are the rules and patterns that define how family members should interact with each other. You know, when the grandfather comes, we get up not because it's not written in the constitution, but because it is a culture, it is a custom. So every family has its own culture, its own custom, but society has its own culture. They can improve relationship and increase the self-esteem of people. Three type of boundaries are there. One, the diffuse one, a clear one, or rigid one. The worst is rigid one because nothing goes out of the family. So a person can be having problem and the world won't come out, come to knowledge of it. Whereas there is something called porous family. That means few things leak out, but still it is sort of close. And a clear boundary may be there, and which may be porous, completely porous or open. Open also cannot be there. Rigid and open cannot be there. Open means whatever happens here, everybody knows. Don't do that. Now, what are the tips for setting and maintaining boundaries within the family? The words are important. We should be clear about what are the rules. We should be firm about how to implement the rules, whether it is child or adolescent or even father or grandparents also. Sometimes we may have to implement rules for the grandparents also. Not because they are, not because they don't listen, but because the age is such that some rules is required. You can't do this. You can't do that. Communicate openly. That's the most important. Maintain realistic expectation. Be willing to walk away. Sometimes you may have to walk away temporarily or permanently even sometimes. Okay, that is very important. The four common boundaries are: the physical boundary means what kind of rules do you want to maintain about your physical body and personal space. You are going to talk to a young girl, how much distance you must keep, how much distance she must keep with you. That is something important. Moral boundaries are what are the morals and values of the family. That is very important. Because, every family it is different. It's different in the village, it's different in the city. But when you shift from one place to other place, you also need to know what is the morals and structure of that family. I was in Punjab for 10 years. When I came back, I had a habit of hugging everybody because Punjab, that is very common. But that's not common at all in Kerala. So quickly I realized that it is inappropriate in this culture. Although that is the most affectionate way of greeting in Punjab or Delhi for that matter. So that we should learn. Emotional, what boundary do you have related to your thoughts and feelings? Can you separate your feeling from other people's feeling? It's very important that you may have certain feelings, but also we need to respect other family members' feelings. So sometimes you don't say anything because you don't want to hurt the family. That is important because you have to respect other person's feeling and separate it from your feeling. You may agree or disagree, but doesn't mean the family has to agree or disagree. Financial, this is extremely important that are you going to give money to somebody even if they are in trouble? There's no correct answer. Yes or no, it can't be there. But my tip will be, if you give some money to somebody, make sure, you be clear in your mind, you are not going to get it. Okay? He may give it. That's a different story. But even if he doesn't give that money, will it hurt you or not? That's what you say. In thousands, I won't mind. If it is in lakhs, I will mind. So naturally, I'm never going to give in lakhs to anybody. Okay? And don't stand guarantee for anybody. Anybody who has stood guarantee financially, they have been in trouble. So that's very important. Then don't get complicated all this. Just read the last part only. What are the stages of family cycle? You have the unattached young adult who he or she is trying to develop peer relations and career. So at that point, that is important. Friendship with the peers as well as career formation is most important. In a newly married, what is important is making room for spouse and again adjusting career demands depending on a marriage status. Childbearing age, suddenly you take the parenting role and making room for parents who have turned grandparent. By then, your parents will become grandparents. Preschool age, adjusting to the specific needs of the child. Difficult, preschool child is difficult, so naturally you have to make a lot of adjustment with a lot of emotional drain. Now, school age child, allowing the child to establish relationship outside in the family, an extended family. School age child doesn't remain in the small pocket. They want to deal with increased, societal involvement, particularly in the school base. Teenage child, of course, there is balance. Everything is going, shifting the balance in parent-child relationship. Till yesterday, they can't do anything without your help, without your consultation. Now they start asking, why should I do it? Why that is correct? Why should I do like that? Don't think it's negative. It's not all negative. He is exerting himself to become a future adult. Every parent only needs that. The moment they object to what you are saying, it is not enmity, it is not anger, it is belittling you, nothing of that sort. You should be proud inside, not outside, but inside, that your child is becoming learning to become an adult. Of course, launching center, that probably is a word that we are using to say at some point in life, after your education is over, you are married, little bit settled, you have a child. That is where you put all your focus on what you want to become in life. It may be career, it may be something else. That launch pad, that is very important. Then, of course, middle age, you are rebuilding the marriage, you are welcoming the grandchildren, you are making adjustment for the grandchildren. And suddenly your personality change all completely. A rigid person become very open, you become a much better grandparent. And of course, retirement. This is the most difficult part of any human being. And whoever is listening to me, if you can prepare for your retirement, then you are the luckiest person on earth. Not amount of crores in your bank account. You can't do anything with that. The day you retire officially from the whatever job, you must have something to do next day. That you must plan. I retired on 28th October as Vice Chancellor. The next 29th morning, I joined a Child Development Center. Big or small job doesn't matter, but you have to have something to do. Nothing to do is the biggest problem in life. Now, don't take this complicated slide seriously. I'll just put it in 3 words. There are 3 stakeholders for family therapy. Of course, the first is the child, then you have the parent, and then you have the therapist. And what you require, don't try to read all this, just I will tell you, when you deal with the child, you have to be friendly, really fun, close, empathetic, all that. When you deal with parents, you have to show commitment and good disposition. You talk to them seriously. Now, no playing fool with the parent so much. With you play fool with the child, but you be little more serious with the parent and become a collaborative partner for making the child. Then the family therapy will become successful. Now, what is family therapy to begin with? It's a type of psychotherapy that helps improve relationships and behavior within a family unit. And there has been no person in this world who have achieved anything without having a happy family. And family is the most important, whoever you may be, any high position you may be sitting, but you will be uncomfortable unless you have a good family. So it may be mental health, family dynamics, and individual problem. What is family dynamics? It's a fluid thing. It's a dynamically changing thing, family. It has the relation to power structure, lot of power structure. Who is important? At certain age, you are the decision maker. You are everything. Now, I have also reached an age where my 2 sons have grown up and now they are making decision on their own. If they feel like, they can consult me. Even if they made a mistake, I'm not going to tell them, you made a mistake, why didn't you consult me? No, you have no business to do it. You are near the retirement age. Now let them do. They are in the peak of their career. Let them do it themselves, make mistake, learn by the mistake, and next time they will do better. So that is important. Then what is also important is family therapy is different from individual counseling. Individual counseling, you look at the three things: the affect or the feelings, the behavior, connection or cognition. You are playing with three words: cognition, connection, and affect. But in family therapy, you are not playing like that. It is family dynamics, family power structure, how each one look at each other, who has the power. Power doesn't mean money alone. Money may be an indicator of power, but more than money, who decide things in life. And most great people, they pretend they are the last word in the house, but the fact is their wife is the last word in the house, directly or indirectly. And the day you accept that fact, you are the happiest person on earth, because you have no problem at home. Leave that thing to her. Don't take the responsibility. Family therapy is a form of talk therapy. Okay. Now, I was wondering how to structure the talk. Then I got a beautiful performer from Nimhans, which is beautiful one. I didn't retype it, but I think it's come because there's hardly little time was less. So I'll just say the structure only. If you ever plan to do family therapy, take three things you must do. First one, some experience with somebody who has done it. Get exposed to how people do family therapy. Not a certification as such, but at least you must see it. And that is very important. And one of the best centers in India is Nimhans. So for family therapy is one of the best centers. So if you possible, go and see what they are doing. That is number one. Number two, learn to follow this assessment performer. Do at least 10, so the 11th one you can do properly. That is most important. And third one, the family dynamics is not as simple as we think. Individual counseling an adolescent is much easier. But family, they are difficult people. They are very rigid people, and you cannot break there. Every word you say can get you into trouble. So you may have to be, and already pediatrician know, because between mother and mother-in-law and daughter-in-law, how you manage, keep both happy. You have done that. So first thing you must know about the family structure. I won't go into detail here. We are talking about boundaries and systems and subsystem. This is an important word in sociology. System means family is a system. Okay. And within the system, there are subsystems of power equation, like father and son, maybe daughter and mother, or father and mother, or children all together. They gang up together. We call it alignment. We may call it coalition. Coalition is more loose. Alignment is there, or coalition. Then that is very important. Second one is leader. So first one is system and subsystem. How do they help each other? They go against each other. That is the number one. Number two is a leadership pattern. We will talk about it. What are the leadership pattern? That is a power structure. I already talked about it. Third one is role of structure and functioning. The role conflict, the accountability and acceptance. Most people give advice in the family and take it, but they don't take accountability. Everything comes on the poor mother. The decision might have been taken by the husband, but wife get the blame because everything comes on her. So that is not good. We won't go into all further detail. Communication. What is the pattern of communication? They may be affectionate members of the family, but their way of communication may not be appropriate. We won't go into details of communication, but it may be direct communication, indirect communication. Direct communication is okay, but mostly within family, everything is indirect communication. It may be non-verbal communication. Okay. So if you are sitting as a family therapist, you should be able to read from the eyes of the person, each person sitting, what they are saying and what they actually have in mind may be entirely different. You should learn to, catch all those things. Then reinforcement. You must understand what is reinforcing a particular behavior of a particular member of the family. Till now, we said particular behavior of that child sitting in front or adolescent sitting in front. Here, the behavior and social control of individual members need to be taken care, and you have to have a feel of that. Cohesiveness of family. Is it a very strong knit family? Enmeshed means, they really miss. There may be problem, but the problem is they're taken care of. They don't try to blame each other for the problem. They take responsibility together. I said, okay, we have a problem. We are together. We will do it. Then adaptive patterns. How do you have conflict resolution, problem solving? You can understand from the way each one talk about the problem. You can understand, is it a destructive way? Is it a blaming way? Or is it a positive way? Okay, happens. What happened? Doesn't matter. Doesn't matter. And family doesn't mean only a house. Family, if you are running a unit, if you are running a center, that also is a family. And the head of the family or the director has to have all these qualifications. Then social support system. How do you get it? Whether you have a support system or not. So all this much you must have idea of it before you start doing family therapy. Then what is the function of a family therapist? Of course, you have to bring good rapport with all family members. Not easy because each one may be at each other's throat. So it may not be easy, but you have to somehow use the rapport, deal with conflicts and ways of coping with it. Okay. So you need to identify the conflict and the inner reason for the conflict. That's what it. Just like Freud's talked about the childhood experiences. You are going in deeper into subconscious mind, unconscious mind. Similarly, the family also has subconscious mind in a different way. They may be saying something so smooth about the daughter-in-law, but the inner feeling may not be the same. So you need to catch that. That is the most important part. Clarify conflict and dissolving barriers and misunderstanding. And you have to put on paper what are the conflict. Only if you can put on the paper, you can discuss with both the parties what are the conflict. How do you think we can get over it? Give the responsibility to that person. Okay, not take the responsibility and take all the blame on you. You need the person to give solutions. Just like individual counseling, we give the choice to the child. Okay, bring family accurate information of what is wrong. In the end, you may have, whether they like it or not, you may have to say, to my understanding of doing this therapy with you or session with you, I believe this is the problem. I may be wrong sometimes, but if I am wrong, you correct me. That's the best method summarizing. Then what is a family therapist functions? He's an activator, somebody who motivates, somebody who challenges you. Hey, can you do it? We can do it. Can you do it? He's also a supporter. Even while challenging, you're also supporting. You are an interpreter of relations. Very difficult to interpret relation, but you can do it. Because you have done counseling. Then you reintegrator. If there is a break somewhere, you need to reintegrate the same thing. Ultimately, you become an educator to the family members. Now, family interventions are plenty. What we can do is sometimes you may have to counteract inappropriate denials and conflicts. Somebody is denying it, it is not there. You may have to counter it. I don't think so. Can you come out little more on that? Lifting hidden intrapersonal conflict to good interpersonal. Intrapersonal conflict may be so hidden, you won't understand. But from their language, from their eye movement, from the way they smile, the way they talk when they are saying, you should be able to pick up and use it to correct it. Through confrontation sometimes and interpretation. Confrontation is not a good thing to do all the time, but you may have to confront somebody saying that, you said like this, you are saying this is the problem in the family, but I don't agree with you. There is a problem. Could it be like this? I believe it may be like this. Then they may come out with it. Reduce the intensity of shared currents of conflict, guilt, and fear. Although the person may look so bad, actually that family member is not bad. He himself or she has her own emotional conflict, guilt feeling, and fear. That is important. So whenever there is conflict, our aim should be to increase the positives and decrease the negative. Increase the positive, decrease the negative. And then family intervention has other roles also, like you become a true parent figure. Fulfill the role of a true parent figure who has no emotional attachment to anyone or anything. You are separated from the family, but at the same time, you think for the goodness of the family. A control of danger is something dangerous going to happen. You may have to be a source of controlling, a source of emotional support and satisfaction. Some members of the family may need emotional support. You may have to offer it. Supplying elements that the family needs but lacks. Supplying doesn't mean supplying physical infrastructure or physical things, the things that contact, connection between people is not there, you may have to try to connect that. Serves as a personal instrument of reality testing for the family. Reality testing. At the end of three or 5 or 6 sessions or 3 or 4 sessions, the family should understand what are the problem, what is the reality. That's called reality testing. But all this depends on two persons, the father and mother, the parent. Grandparents are all important, but not real. The parent is important, depending on what type of parenting he is doing or she is doing. The worst, of course, is authoritarian. Focus on obedience, punishment, and discipline. Okay, old parents were, sometimes grandparents, old parents were like that. Now, on the other side, they have become permissive. Don't enforce rule, kids will be kids, let them do what they want. It's just like the American style. Don't do that. Don't just let off. It may actually help some children to develop personality and talent and all that, but overall development will not come. The third, of course, is uninvolved. I'm not bothered. Do what you want. I do what I want. You do what you want. That also cannot be. And the fourth, of course, is the best authoritative. Create positive relationship, enforce rules, be firm but not harsh. That's most important. Then don't try to read everything. Just read the last part. Authoritative means you are going to have an adolescent who is responsible behavior, self-assured, and socially skilled. Authoritarian, that means hard parent, it become a non-confident, passive, social adept person. If you have very much intelligent parent, the adolescent is likely to be immature, irresponsible, etc. If you are a neglectful one, then he may be impulsive, defiant, and delinquent. Okay. Now, CBT has a great role in family therapy, but I can't spend time on this because 30 minutes you can't do it. So I'm just mentioning 3 important methods that we use. One is structured intervention help with behavior problem, particularly in ODD. It may be structured intervention for ODD. That may be a great thing. Combined parent-child cognitive behavior therapy to improve empathy for children, positive parenting skills, and family relationship. Okay, I can't go into detail, look, lack of time. Parent-led CBT, help prevent and reduce parental burnout. Please read on these 3 things if you're seriously planning family therapy. Simple way, I'll tell you what is a model. There is a attitudinal engagement as well as behavioral engagement. Attitude engagement is expectation that treatment will be helpful. Motivation to participate, that we need to create in the family members. And behavioral engagement, you may have to participate, the child, parent participation, attendance, and help-seeking initiation. Just like madam was saying, they go away, they don't come back. That part you take care of by this. A link should be created, just like the serials, you have before they stop, they will give something click so that next time you want to come back. Do some technique like that. Invariably, they'll give some bits of piece so that you will be curious to know what is happening next time. So make sure that attendance is there, help seeking is there, and that only can be done by creating that curiosity. Now, family education is the most important in India, and family and education. What is happening? There are 2 types of family. Family of procreation, or where you were born, and family of orientation that people create. You create your own family. There were rules and regulations in the family that you were born and brought up, but you may create your own family and rules and regulation, which may be based on your parental rules and regulation, but it may be totally different also. That is important. Family intervention for NDD child, I think it's important to talk about that, because psychoeducation based on psychosocial rehabilitation, narrative therapy help people view problems objectively, and you have a play therapy, of course, drawing, role play, games help. What I found in most child development centers or therapy centers is, we give lot of advice, counseling, all that guidance, but we don't have activity space. Okay, so for autism, the best treatment is actually group therapy and individual therapy. More than individual therapy is a group therapy, which will actually last month also we sent 20 children to the school, because the group therapy is based on what is the routine in the school. The child get used to that. You have to have group therapy for ADHD children. You have to have for learning club, learners club we call it. So learners club is where actually we take care of simple. No point in advising a parent, do like this, he will improve. No. In front of them, you show how it can be done. Let the parent realize the difficulty of the child. And then the parent may repeat, ask them to repeat what you did here in the center. So every CDC, every child development center should have activity space. A lot of activity has to be there. Of course, doctors can't do it, so you need an assistant. That's why we have developmental therapists. They will do the job. You don't have to do that. Then, of course, interpersonal psychotherapy, particularly if you buffer against depression, strategy therapy, I can't go into all details, so I'll leave it. Guidelines for conducting interventions with families. This is the rules, the basic rules. Inform clients reason why family is seen together. You have to inform them why have I called all you together. Timing for appointment. It has to be by appointment. Don't take it lightly. You walk in anytime you want. No. And if arriving late may actually reduce your time, tell them clearly. You may have excuses, but here the timing will be reduced. That is important. Any cancellation session to be informed in advance. Session location to be intimated in advance. Number of expected family session to be informed in the beginning. Expected sessions. You can't say you said 5, it may go to 6. Doesn't matter, but at least what is expected. Clients to avoid verbal arguments during the session. You should not encourage any verbal argument. This is not a court. It's not a play where argue and win. It's not argue. It is we trying to understand, even to the person who's trying to get angry and argue. Okay, I understand your feeling, but can we put it into what actually the fact that you want to say. You say the fact without emotion. That is the most important part. The moment you emotion, your voice will raise, and you will be abusing the family member in front of you. Don't encourage such behavior. Okay. Then, of course, we need to have a balance between materiality and spirituality. And if you don't have that balance, you won't be. Because if you are materialistic thinking, everything is materialistic, you can't forget and forgive, you can't, renunciate something. So it has to be a balance between the two. So the last word I will say is the spirituality. What are the spirituality? Nothing in this world works without spirituality. All the people who argued that it is wrong, it is this thing. You must remember one thing. I always say the religion, the spirituality element, spirituality is not religion, but our understanding of spirituality is linked with religion. So what we say, there are 3 things in that one. You have the basic core principles of religion. God is truth, God is love, God is that concept. Then you have the pathway to reach God. Okay, every religion has their own pathway to reach God. And third, of course, is in a religion, there will be corporate culture. Good and bad. Corporate culture will be there. So every religion has this problem. I'm not saying more about it because I don't want controversy unnecessarily. But every religion has. I have done MA in philosophy, religion, and I've learned 7 religions. All say the same thing. Absolutely no difference. But the way to reach God, that they call theology. Theology. You have seen Christians done PhD in theology. Theology is the pathway to reach God. That may be different in each religion. And the third one is also same. So what is spirituality? Spiritual achievement is possible only when we increase our own worth. When you say, I am worth it, what Maslow said, Maslow also, you remember, from basic needs to reach to self-esteem and self-actualization. At this age of life, we should be thinking of self-actualization, not about amassing wealth, not about enjoying more, not about everything. Your enjoyment now is the time when society, you want to give back to society. So that's important. Understanding our own hidden worth. Very often we never understand until somebody point out to you that you have so much of hidden worth. And after retirement, some people recognize their hidden worth, or some people totally go into, lapse. So refining our personality needs three things: purity in belief, purity in thinking, and purity in action. When you go out from here, just remember these three words. Almost all of us are either middle age or nearing retirement. So remember, purity in belief, purity in thinking, and purity in action. If you have these three, you are capable of, even without training, you are capable of doing a family therapy, which is not perfect as per the standard rules, but at least you can help family. And that's what pediatricians have been doing without training. Thank you. Thank you very much. 10:15. I've taken 30 minutes. Okay.
Thank you, sir. And thanks a lot for the perfect completion in the time what you have committed, 30 minutes, exactly 30 minutes. So thanks a lot for such a discussion. That is the most demanding topic, I think. And now I would like to request our chairperson, Dr. Pooja Dupa ma'am, senior consultant pediatrician and intensivist from Raipur, to share her insight about the talk and take the question answer session.
Yeah, good morning, sir. It was such an excellent talk. No words to say the excellence of the content which I could hear. Actually, I'm a pediatric intensivist. I stopped the round of ICU and I was listening to each and every ball. And really, that spirituality that is being built up in our inbuilt with the knowledge and wisdom is definitely helps not only the patients and definitely the entire family. And the spirituality should begin from childhood, sir. What I feel like it should begin from the very first day, like when the baby starts listening to the parents, what in the local language, what they understand, it should begin that way. And I think it was an excellent talk, sir. No words to express the excellence of the content, sir. Are there any questions? Yeah.
Let me check, ma'am.
Yeah.
It's a relatively new topic. It takes time for people to digest what I said. So, Preeti, what we need is we need to have more sessions on family therapy. It needs a whole day to really do family therapy. Within 30 minutes, you can only give glimpses of it. So I think people have difficulty in absorbing the whole thing because they're not used to listening to this, just like adolescent counseling. They won't be.
Yes, sir. Yes, sir. We can do a workshop.
Yeah. You need to have a one full day workshop.
Yes, yes, sir.
With person who has actually been doing for many years. Yeah.
Yes.
So there is a question that any guidance for the adolescents who claim to be atheist, sir?
Atheist? Okay.
Yeah. Adolescents who claim to be atheists.
See, basically, adolescent is a time when they deny everything else. Let it be. If you try to put things into his head or her head, he or she is going to become more rebel. Just leaving like that. The day he gets his first child, atheist also may turn out to be 99% may turn out to be a believer. Take for. And particularly in Hindu philosophy, Lord Krishna had said, though the one who believe in me and one who reject me, both are very dear to me. You understand? Here you are taught to ask questions. In Hindu philosophy, whether it's Lord Krishna or anybody you talk about, gurus, they only teach you to ask questions. And in adolescent age, when you ask question, if you don't get a clear-cut answer, you reject the whole idea. That's okay, perfect. Why I said the first child, insecurity start coming when you can't do anything yourself. That comes when it only with your child. And suddenly you start becoming a believer. I have seen umpteen number of people doing it. So don't push anything on adolescent. You show by example, but never try to push. That's all.
So one more question in the family therapy. Suppose usually happens like the parents, either the spouse, father or the mother, they don't accept like who might be the responsible. Sometimes the father might be more caring for the child, and maybe the problem with the mother, but they don't want to like come together to share the problems, and they don't want to listen together. Then how to tackle in such situations?
No, you convince them that both of you are like two eyes of mine. or yours. You can't say, you see with both eyes. You don't see with one eye. Okay? The share may be, right eye may be taking more shares sometime, the left eye may be taking. That is a philosophical approach. Then practical approach, it may not be question of taking responsibility. It may be he or she may have a lot of other grievance of being neglected. You understood? She is saying this man is not taking any responsibility when she feel neglected and think that he is not doing many other responsibilities. What he told about his childcare, but what she actually mean is something else entirely different. So you need to have the intricacy to understand from the reaction of the woman or reaction of the father what it is. And one of the easiest thing I do is when the child come in, I say, I just showed like this. Which one is impossible? Scratchy. I showed like this. Which one is scratchy? And then they will say, almost always say the mother. Now, then look at how each one laugh. Okay. If they have a good relation, both will laugh it out. But if they don't have a relation, the father will become suddenly stiff, look at you as if dirty fellow, what are you asking? Like that. Immediately, he is an impossible person. You understood? Little tricks you may have to do with that. Very light language, not blaming. Just asking the child who is this, which one. And the child will tell the truth actually.
Yes.
Child will tell the truth in front of them. And that is the best way to counsel.
So one more question that what are the scenarios where a pediatrician should refrain from family therapy?
No, don't conduct formal family therapy unless you have a setup, you have assistant, and you have a space for that and all that. You are not primarily trained for family therapy. But if you have a psychologist, sociologist, or social, rehabilitation person, somebody who is into this field, then you can organize, you can be the team leader, but you need somebody else. Pediatrician cannot have the time to conduct a proper family therapy. So it can only, what we can do is an IAP branch in a district branch, they can start a family therapy unit for the children. But wherever you have, you refer to there. Or have your child development center. Every child development center should have a family therapy, not every pediatrician. Family therapy is not like individual therapy. It's a very labor intensive, time intensive, and emotion intensive. Don't think you are going to get all positive stroke from all these people. You yourself may become emotional, problem because of the bad negative stroke coming from the family member. You know that if some two people are fighting, husband and wife is fighting, if you interfere, what happens? You become the victim. You become the bad person. So what I normally do is even family counseling, counsel them separately first, entirely separate, two person. The wife is coming to me, the wife has problem. I will help you to get over your problem. Husband, I will help you. Then maybe you can have common sessions. Similarly, family also, same thing. Okay.
So how to deal with cynics? It is a great challenge for the pediatricians.
Just give me an example of what do you mean by that? Cynic, I understand the word meaning, but what exactly you mean?
So I don't understand that. Practically, I don't know. That is a question in the chat box I have received, sir.
Yes, most of us are cynics. We never believe in that something will happen. It's all going to be, it's useless. This country will never improve. India is like this, gone case, this. Most of us are cynic in most of our things. But in a counseling situation, there may be deeper meaning to being cynic. That's why I said, if I get the context, it will be able to answer. Otherwise, cynic only means that somebody who doesn't accept reality, who actually challenge every reality and try to laugh it off.
So what I think it means is that family counseling is of no use. I am not going to come for counseling.
Okay,
I mean,
okay.
That kind of a thing. It's not useful.
If that is the thing, you can only demonstrate only by showing success. And how do you show? Even parents sometimes become cynic. You keep on treating and still they'll say nothing is going to happen. But when things happen, I'm sure if you're dealing with an adolescent, Preeti will be able to say, most of her parents would have been partly cynic to begin with, that this boy is not going to improve. But you don't know, at one point, suddenly they will start melt and they become different. And then that is the most convinced parent. So when you are doing therapy next time, actually bring that parent. In fact, I do it for autism. The mothers, I have one or two mothers who is learning with me, and she's the team leader for mothers. Because when she says, they get convinced. My child had this problem. This is what I did. A child has improved. But if the doctor says, they won't listen. So cynic, you catch hold of somebody who is with you, who actually was cynic, but then change because they show positive result. Okay.
And sir, how is the family therapy different from marriage counseling?
Oh, marriage counseling is basically between two people. They are the focus. See, all these are little different. Basically, all are the same. Now, if even in marriage counseling, at some point you may need family therapy. But if your individual has a problem like anxiety, depression, you only talk to the individual 90% of the time, 10% you may talk to the parents. In a marriage counseling, you are spending 80 to 90% of the time between the couple. It's also called couple therapy. But there may be grandmother involved or mother-in-law involved. Then ultimately, family pathology it is called. In a family therapy is for family pathology. There is a defunct or difficult family pathology. We call it family pathology. If there's a family pathology, then the family members has to be there. Other one may be ego problem between the couple. Okay, that is only a pathology at the couple level. Individual means pathology at the individual level. Got it? But ultimately, all of this may need one session of family therapy. May need even couple difficulty. There's a ramification with the mother-in-law, ramification with father-in-law, in-laws, and all that. But then normally we don't try because in family, in marriage therapy, it's better not to involve other people into your personal life. Are you getting me? So
Yes,
unless it is pathology is severe in a marriage counseling, you don't try to involve other people because your secrets, other people, you can't share with other people. What the couple has want to express is private and only for you. Whereas in family pathology, it is not personalized. It is the pathology of the family. I am telling you, your building is not strong. It has leakage here, it has leakage here. Do you get insulted by that? You don't. Okay. It is something like that. That's why I said, okay.
Okay. So, sir, while doing with the family therapy, while dealing with the adolescent issues, so they even call grandparents. So, can we call grandparents during the family therapy?
Now, problem, don't try to call it family therapy. There you are calling grandparents because they are also a stakeholder to the problem of the child.
Okay.
See, separate out these two. If your child has a problem, suppose your child has a problem, we may call your mother-in-law because she is also a stakeholder in creating that problem for the child or reducing the problem. But that is not family therapy. Okay, family therapy is a structured therapy in which each family, we are identifying the family pathology. What is going wrong in relation depending on those 8-10 items I said. Family connectedness, family relation like that. It's a systematic therapy method.
And sir, one last question. What would be a realistic success rate at rescuing families?
No, I won't be able to say because, seriously, I have not done family therapy as a profession. You understand my pain? Adolescent, you ask me, I'll give you, 10,000, 20,000, 75,000. Family therapy, I have not done so seriously, so I won't be able to give a correct answer to that. I think NIMHANS, you can ask Shekhar Seshadri, he may be able to give the answer to that. Because Vellore, they do it in CMC Vellore, they do it in NIMHANS. NIMHANS, there is a section on that, a division on family therapy with professor, associate professor, and all that. So they will be able to give a accurate data. I won't be able to suggest.
Okay. So even if the family is a joint family, then also the grandparents are not called?
No, calling grandparents is different from conducting a formal family therapy session. I think that structure you are not got into your mind. That's the problem. Family therapy, we are not looking at a problem and what are the root map of all this problem. In family therapy, we are looking at what is the primary problem in the family dynamics. family power structure. Get a family power structure. There you need to talk, but don't talk personal things too much there. In family therapy, we don't try to identify the person. You are responsible. This one is responsible. You are trying to say what is wrong. That's why I said the building. Building, is it a construction problem? Is it a structural problem? Is it a leakage? Is it something electric problem like that? Yeah, got it.
There should be no blame game.
No blame game. Absolutely.
No.
I think you have summarized it nicely. No
Yes.
blame game.
No
Correct.
blame. Yes.
Thank you, ma'am. I think questions has been over now in chat box.
Yeah. So,
Okay.
yes, sir. There's one more question. If there is a single parent, if single parents, then what should be the process? It will be the same.
No, it will be same. Let's not get into that. Otherwise, Shekhar's time will go away.
Yes. Sir.
Already we are late.
Yes. Yes.
So thank you, Pooja ma'am, and thank you, MKC sir, for such a wonderful question answer session. Now, may I take the privilege to introduce our next chairperson for the our next gripping session, Dr. Harish Naik sir. He is a senior consultant pediatrician practicing since 35 years, director of Child Care Clinic and Nursing Home Korba, past president of CGIAP 2020, and the organizing chairperson of CG Pedicon 2005 and 2012. I would like to invite sir to share his valuable thoughts and introduce our next guest speaker, Dr. Shekhar Seshadri sir, for his session.
Thank you, Dr. Silpa, for your kind words. And after the talk of Dr. Nair sir, very important talk and very informative talk by that. Dr. Shekhar will take the next session, and thanks to CGHA for giving me opportunity to chair the session of this important grand round, a marathon round, I can say, from 11 a.m. to 4 p.m. And next session will be taken by Dr. Shekhar. And we know that Dr. Shekhar is a child psychiatrist, and he doesn't require although any introduction, but it is my duty. And Dr. Shekhar is a child psychiatrist for over 35 years of the experience in the field of the child mental health. As a former senior professor in the Department of the Child and Adolescent Psychiatry in AIMHS, his work has extended beyond the clinical population to children and the child care institution and service provider across the country as well as the South Asia region. Some of his special area of interest are childhood trauma, gender and sexual issues, and the life skill education. Also an artist and musician, great. He used a number of the creative methodology in the child mental health intervention, including the theater and the developmental approach. In the belief that wider psychosocial intervention are rooted in the child rights, in addition to it, preventive, promotive, and curative child mental health intervention, he has undertaken various legal and policy-related initiatives. He was a part of the national deliberation on the PASCO Act of 2012 during its drafting, and more recently, an active part of the debate around the December 2015 Juvenile Justice Act. He has also engaged extensively as a member of the working group of the National Commission for the Protection of the Child Right on issues such as the substance abuse and elimination of the corporal punishment from the school. Finally, all his policy and practice work find this way into the training and capacity building program for the target audience ranging from the student of the mental health discipline and health discipline, clinical setting, including the community health worker, teachers, government and the government staff and the counselor and the judicial personnel. The NIMHANS Community Child Health Adolescent Mental Health Services Project was conceptualized and initiated by Dr. Shekhar. It is a great work as a part of his vision for enabling access to the mental health for the most vulnerable of the child population. This is how extended into Samvad, that is support, advocacy, and mental health intervention for the children in vulnerable circumstances and distress. A national initiative and integrated source for the child protection, mental health, and psychological care. Again, it's supported by the Ministry of Women and Child Development, Government of India. So this is great job done by Dr. Shekhar and great personality in the field of the child psychiatrist. So I invite Dr. Shekhar to start his deliberation.
Thank you very much, sir. Thank you. And thank you, all the people who are involved in the organization of this remarkable series. Just to segue a bit from the last point that MKC was making to the penultimate question, there's a difference between art therapy and art-based practice. Similarly, there's a difference between family therapy and family-based practice. As MKC points out, family therapy specifically addresses pathology within the family system, whereas family-based practice is you may work with the extended family. Let's say in caregiving of a special needs child, what role could the grandparents play? That's family-based practice. That's the distinction that you need to understand. They are both legitimate, they're both serious endeavors, but essentially that's the difference that we need to keep in mind. Having said that, what I wish to share with you, with the 120 of you who are left on the session, 14 seem to have dropped out, but that's all right. I have divided the time till 4 o'clock into 7 segments, and I will keep them pithy and sharp so that you would be able to have a sense of the frame of reference as far as child sexual abuse is concerned. I will be giving gaps in between. My original plan was actually to give a break in the pre-lunch session, but since we've gone a little beyond time, let me go straight till 1 o'clock, and we'll take a straight break from 1 o'clock to 2 o'clock for lunch and so on. And then we do a 2 to 4. I'll give a 5 to 10 minute bio break between the 2 to 4 session, and we'll wind up at 4 o'clock. Now, I would like to essentially start with certain preliminaries till the lunchtime. And I'd essentially like to start with the experience and impact of child trauma itself to begin with, as you see on the screen. As the chairperson pointed out, I do represent Samvad, which is a national initiative established by MOWCD, located in Nimhans, where I continue to work in an advisory capacity full-time after I retired 3 years ago. We are operational in 28 states and 6 union territories, so we do extensive work across the country. Now, the objectives, friends, that I've put for you are not just objectives for this learning session, but they are also objectives that you may keep in mind in clinical practice. When a family comes to you, when a child comes to you, and you suspect that the child may be dealing with trauma, one aspect of trauma being child sexual abuse. So if a child is in the clinic, how do you really understand the experience of trauma? How do you learn about the nature and its impact? And if you have a frame of reference of some of the basic mental health problems that result from trauma experiences, your pediatric practice becomes that much more nuanced, and you go beyond the diagnosis of medical disease to look at the social context from which the child comes. So the child may come to a pediatrician, as Kavita pointed out in the beginning, let's say with recurrent UTI or chronic UTI. And the reason I'm talking about the importance of understanding the context of trauma in something as simple as UTI is this. Friends, just listen to this story. A child is in a family where there is a neglectful mother and a disinterested father. There is a domestic help who works at home with questionable hygiene, who keeps on handling and fingering the child, and the child develops UTI, is brought to a pediatrician, You do the basic necessary, which any good pediatrician does. And the child comes back with a repeat infection, and another one, and another one. And then, as Kavita pointed out, there is an index of suspicion. Why is this child having repeated UTI? What is the source of this UTI? Now, in the particular child that I'm referring to, who I had the honor and privilege of assisting, when the recurrent UTI went on till almost adolescence, when the person in question, the perpetrator, for some circumstances left home, by which time it had extended into pyelonephritis, had extended into kidney disease. And at age 18, this individual had to have unilateral nephrectomy. And the question she put to me when I was in a therapeutic discourse with her, she said, "Doc, organ loss is a very heavy price to pay for neglect and for UTI and for child abuse." Organ loss. No, mind you, we may say these days in the dispensation in POCSO, rape, murder takes place. I mean, children are killed. That's not my point. I recognize the seriousness and significance of that. But as pediatricians, I mean, can you imagine loss of a kidney, organ loss because of child sexual abuse is a very heavy price to pay. Which is why in our practice, if you're alert to the kind of experiences children come with, it makes a lot of difference. So let's do an activity. Let's think about what trauma means. Let's understand what trauma and how we view it. Just for a minute, friends, just close your eyes and think of a traumatic event in your lives at any stage in your life, in childhood. Imagine the event and the time as an image, not in words, not as a narrative, but as an image, like a still photograph. Now, if I were to ask you to draw it and to describe it, what sort of images and feelings come back to you? Was it easy to express the emotions that you felt? This is the kind of activity that we do in our training programs, using visualization, drawings and narrative, using paper, pencils. Every pediatrician with a social pediatrics orientation, with a child safety, child protection orientation, as a member of iCounsel, as a pediatrician who thinks of an obligation for social advocacy and activism and really wants to work in the area of child trauma and safety, would keep in his or her clinic a whole set of this kind of materials to get into the inner world of the child. What is trauma? It's an emotional, psychological, and physiological residue left over from heightened stress that accompanies the experience of threat, violence, or life-changing events. It's more overwhelming than a person would be ordinarily expected to encounter. The unfortunate truth, friends, is there is now something known as complex trauma and adverse childhood experiences. Children are often exposed to multiple traumatic events. They're invasive, they're interpersonal, they are wide-ranging, and they have long-term effects due to this exposure, not the least of which, as I mentioned, is organ loss. But there are other serious psychological, relationship consequences, well-being consequences, mental health consequences, social functioning consequences. If our current pandemic, COVID, was a current pandemic, adverse childhood experiences has been an everlasting epidemic. So when we see a child in a pediatric clinic, for whatever, it may be fever, it may be asthma, it may be nephrotic syndrome, it may be UTI, it may be diarrhea. How alert are we to taking the history that MKC pointed out in the slide that he presented on the NIMHANS format? And if as a practice we do this, We understand the social and family context that the child comes in. Sure, I will treat the UTI, and the UTI is not because of sexual abuse. But this child also comes from a family where I have understood that there is marital conflict. I have understood this is a single parent family and the surviving parent is struggling. I have understood that they have intact parents, the parents have a good relationship, but the father or the mother has a chronic health issue. Perhaps diabetes, perhaps cancer, perhaps alcoholism. And what does that do to this child who has UTI, to a child who has UTI but does not have these family circumstances? All this makes a difference in the well being of the child. This really is the traditional concept of the old family doctor, the family pediatrician, who knew not just the disease of the child, but everything about the family was part of their births, their ceremonies, and became a trusted character in their lives and their lives' narrative. In summary, trauma is sudden, it's unexpected, but it can also happen repeatedly and over long periods of time. Children are unprepared, they are powerless, someone was intentionally cruel, and sometimes more than one traumatic event occurs in succession close to each other. Father has an illness, in and out of hospital, mother has depression, there is the death of the father because the mother is struggling, the child is relocated, that's another stress, to what one believes is a caring relative. There the child gets abused. So you see how multiple events occurs one after the other. So to look at the life story of a child, their daily lives, the epoch that existed prior to the time that they came to your consultation chamber becomes important. Two types of trauma: acts of omission, neglect, parental non-responsiveness, psychological or physical unavailability often happens in even because of maternal depression. Just to give you an example, friends, will be of great relevance to you, particularly to neonatologists among those of you who are present here. Postnatal depression or postnatal mental illness. Now, perinatal psychiatry has become quite big. NIMHANS has a 4-bedded mother-baby unit. Mother has depression or psychosis, is on psychotropic medication, antipsychotic medication, unable to bond with the child. Also told not to breastfeed because of the secretion of the metabolites of psychotropic medicines in breast milk. If she's psychotic, she may even harbor aggressive or homicidal tendencies towards the child. What happens to the initial holding experiences of the child, which are the first experiences of body integrity that gives rise to oxytocin release that really structure those parts of the brain which are important for emotional regulation? And that's where, under supervision, the mother is taught to bond with the child, to hold. And these are all aspects, even in pediatric practice, for those kids who are brought in the neonatal period to you with some issue or the other, some fever or vomiting or something. But you notice that the mother has postpartum depression, and you can see from the body language that MKC also pointed out. And this becomes part of the practice that you do. But there are acts of commission, actual trauma directed towards child, abuse, physical, sexual, psychological, giving rise to PTSD. So here is the large common traumatic experiences that occur in children's lives that you may want to keep in mind: domestic violence, natural disasters, communal violence. Look at what is happening in Manipur right now: death, dying, bereavement, grief, separation, loss, abuse, trafficking, medical trauma, accidents, disfigurement, loss of limb, terminal illness, torture, difficult experiences, sex and sexuality, violence, gender, patriarchy, power, domination. But it's not limited to these experiences because trauma is relative. Remember what Mark Twain said: nothing that grieves can be called a little. In the eternal laws of proportion, the loss of a doll for a child and the loss of a crown for a king are events of the same magnitude. Child is brought to a pediatrician with sleep disturbance and constant crying and sleep cycle problem, and then not feeding over a period of time. And you do all the examination, you find there is nothing wrong. And then you find out the child actually lost a doll that was dear to her. Either it was stolen or it broke or someone snatched it away. And the child is dealing with a loss experience. It's relative to the child. But see how it has progressed to coming to a pediatric consultation with sleep cycle disturbances, crankiness, irritability, not feeding, throwing up. So, how do you remember and work on the internalization of trauma? What does it depend on? What's the age of the child? Now, very young children may not have the developmental capacities to understand, for understanding or self-regulation. So, we have to respond to trauma with, and they respond to trauma symptoms unless they are shielded by those who are supposed to protect them. And younger children are more dependent on parents' reactions to trauma. So if parents are coping well and they're supportive, and many younger children do not develop long-lasting symptoms. And this is the question that Kavita asked before MKC started his presentation. What happens if I come to know this and I tell something to the parents and they don't come back? Because they don't know how to respond to the child. They are themselves in confusion, in turmoil, in terror. So part of your job is also to allay their anxieties and tell them how important it is for their responses. So if they are quiet and withdrawn and disturbed or crying or agitated, the child is not going to be reassured. This is not to say that their predicament or the impact on them is not legitimate. Of course, they are affected. To recognize and validate that, but also to say that it's important for how you respond and how you reassure the child so that the child is comforted and soothed. A lot of this depends on the child temperament and resilience, the child's perception and coping mechanisms, and what is the source of the trauma. And I will come to the inner voice framework. We'll do a bit of an exercise when we come to this. But essentially, if you recognize what trauma does to a child, it profoundly changes the way in which they see themselves, the world, other people, and relationships. There are issues of trust. There are issues of safety. And these changes are often expressed in thought, cognition, and in emotion. There are psychobiological changes. So there are many categories of trauma symptoms: emotional, behavioral, thought-related, relationship-related. But there's also complex trauma, and there's the whole affect on the body and the biological system. So look at the list of affective trauma symptoms that take place. Emotional. So there is fear. So if you see a child who's fearful, says that I have repeated memories, or is emotionally agitated, there are mood changes, very cranky and irritable, or the child appears to be withdrawn, weepy, or the child is irritable and angry. So look at the realms in which emotional affectation take place. And then there are behaviors, and the behaviors range from modeling of inappropriate behaviors so if they see violence at home, they may demonstrate violence and agitation towards doll or to siblings or toward peers. There may be self-injurious behavior, and in adolescence, the age range of our preoccupation, there may be reckless behavior or high-risk behaviors. There's also parentification. Then there are thought symptoms, changes in their thought of self-blaming. I was abused because I was wearing a short dress. The belief that they are bad, or the perception that no one is trustworthy. They often respond to betrayal of trust by seeking out inappropriate close relationship with the thought process, someone will love me only if I'm sexual with them, or the more someone loves you, the more he hurts you, or self-fulfilling prophecies. My brother died when he was 21 years old. Why should I live a productive life? And there's no point. So to be able to gauge these kind of cognitive symptoms, and then the whole interpersonal interactions, uh, gravitation towards deviant peer groups, because they feel shame and guilt and stigma. They don't share close relationships, or there's a lack of trust and disruption in establishing new relationships. And then there's, of course, PTSD with high levels of dysregulation, dissociation, amnesia, forgetfulness, negative self concept, and so on. Now, all this is mediated through brain functioning and neurotransmitter and hormonal activity and in other parts of the body. So, like new neurobiological connections emerge after the trauma experiences, new responses can be learned to compete with the fear response. And this is what therapy means. How do you respond therapeutically to regulate emotions, to regulate behavior, to change thought processes? And once you explain this to an adolescent, to do so, then the theory of why you do relaxation, why you do imagery exercises, why you do journaling and diary writing, why you do stuff that is aesthetic, things you like, music, art, dance, movement, why you structure your day so that there is predictability. These become the way in which trauma work is done. So children may be brought to you for assistance for some dysregulation or some behavior problem resulting from trauma rather than the trauma itself. So they may come with sleep disturbance to an adolescent practitioner, or they may come with irritability and refusing to eat, or they may come with cutting behaviors, or they may come with withdrawal and some kind of fever symptoms, or fatigue or tiredness. So it's important to inquire about traumatic experiences in history taking, to look at places, people, things, conversations, events, triggers, to understand from an adolescent what the triggers are. A word, my friends, on trauma and attachment. Now, all children, adolescents, they look for secure attachment, healthy relationships, security, feeling understood, comforted, looking for people who are emotionally available. So, if you want to look at when you work with an adolescent in a clinic, do you find that they have the ability to be contained, or do they appear dysregulated? Are they listening? Do they seem to be trusting of what you're saying? Are they communicating well? Are they comfortable being with you in the absence of their parents when you're doing history taking? Are they reflective? When you present a conflict situation that you have understood from the family, do they express an ability to manage it? How do they conceptualize their self-concept and their esteem? Related to this is also the idea of, look at these examples. Neglected or abused children such as foster or adopted population, they manifest different emotional reactions to regain lost relationships. They are frequently reported to have disorganized attachment. They are unlikely to view caregivers as a source of safety. They've learned to adapt to an abusive, inconsistent caregiver, and they have a profound lack of trust and a distorted sense of reality. I'm going to skip some of these. These are going to be difficult to see, except to point out one issue: window of tolerance. When we are in a window of tolerance, life feels comfortable. This applies to all of us, but particularly to adolescents. So in any trauma, there is either fight or flight, or there is freeze reaction. And this ranges between anxiety, irritability on the one hand, or agitation and discomfort on the other. So in your clinical practice, when you tell an adolescent who's in this kind of a situation that there is a window of tolerance, And it'd be nice to look at our bodies in an optimal state so we can access both reason and emotion. We are calm but not tired. We are aware and alert but not anxious. And we can engage with our environment well. Finally, on this part of my presentation, before I segue to the next, there are medical indicators to the impact of trauma. So when an adolescent comes with somatic complaints, sleep and appetite disturbance, urinary tract infection, um, basically autonomic or dermatological. Remember, brain and skin are both of ectodermal origin. You remember in many general hospitals, psychiatry and dermatology are always next to each other. Now we know why. Because embryologically, we know they are both of ectodermal origin, and many features of stress and trauma manifest themselves in skin conditions. So these are medical indicators. Then there are difficulties in emotional regulation, which I have already alluded to. It's, it's like a fan regulator. If it doesn't work, either the fan will not run or it will run only in full speed. So emotional regulation, the way an adolescent comes to you, complaining of anxiety or being numbed or not being in control, or there is substance use, or there's some kind of compulsive behavior or disordered eating. All these are regulatory mechanisms that you need to be aware of. And the third impact is, as I mentioned, when an adolescent tells you in the clinic, the world is not safe, people are dangerous, I don't feel good about myself. I have problems with my body, either overeating or starving, and so on. And then there are intrusive thoughts and memories, flashbacks. These are typical PTSD symptoms. And then there is dissociation, not remembering, amnesia, regressive behaviors, sleepwalking, rapid change in personality from being shy to being aggressive, being in a daze or trance-like state, and then reenactment and what happens through high-risk behaviors or repetitive behaviors in relationships. And then self-harm, very common now, these cutting behaviors, frustration of not being able to tell or disclose or cope, feelings of anger, guilt, shame, feelings of helplessness and powerlessness. And then developmental trajectories, how severe trauma, it can sort of prove to be an obstacle in an adolescent who is otherwise doing well and something traumatic happened, and then, everything goes awry. So let's have a look at this. I hope I'm enabled for, just tell me if you can hear it, in which case.
As we grow, our skills and abilities develop. For each age, we have our developmental milestones. When a child is protected and cared for, their development is age appropriate. However, certain events, stressors, traumatic and abusive experiences can affect the child's development. For example, a 15-year-old child experiences a sudden trauma due to a road accident. Their development is hampered, and there can be an impact on their physical and mental health, which may have long-term effects and can slow down the child's development. Similarly, consider another case of an even younger child who experiences the loss of a parent, a caretaker, or any other attachment figure. The child in this case may develop severe anxiety problems, insecurity, emotional dysregulation, and control problems, impacting the overall development of the child. Other experiences like conflict within the family, neglect, separation, abandonment, child sexual abuse, institutional upbringing, frequent change of caretaker, growing up in conflict areas can similarly have serious impacts on the child's overall development.
So you can see that I'm kind of summarizing. This is what we have presented in this video. So let's end this part of what I wish to share with you with, and you can use the chat option. Look at these cases. We will ignore the 4-year-old and the 6-year-old, but let's go to the 13 and the 15-year-old, or perhaps even to, let's say, let's take the case number 10. 16-year-old Alicia grew up in a household where there was domestic violence. Since she was a young child, she had witnessed her father frequently hit her mother. She was a young child, and mother was usually angry or depressed and seldom had time for Alicia. She often also beat Alicia throughout her childhood years and had rarely shown her affection or care. And now she has a boyfriend who physically abuses her, but she does not want to leave him. She says he's only like that because he loves me very much. You would not understand. You can use the chat option and tell us what kind of trauma do you see in this child. Use the chat option liberally. Any one or two comments? Yes, I see a couple coming in. There is physical trauma, there is psychological trauma. Swati says she equates violence with love. Padma Lochini says there's a lack of attachment and the need for the same outside the family. Geeta validates it, lack of love. Lakshmi says ACEs, leading to attachment issue. Jagdish says dysfunctional family parenting style and domestic violence. Jagdish Kumar, feelings of isolation. Tripti, lonely teenager, emotional, physical, psychological trauma. Shivu Bajpai says love and loneliness. Excellent start, my friends. Let's go one case back. 13-year-old Beena was sexually abused by her uncle while sleeping over at his house. Her parents told her not to disclose this to anyone and that it was a family secret. The girl is afraid of sleeping over anywhere away from home. She refuses to go to sleepovers at her best friend's house. Her best friend was also hurt and angry. Then Beena did not want to be friends with her. And so Beena lost her best friend at a time and she really needed friends. What are your thoughts on this case? "13-year-old Beena. What all is happening in her life?" Well, we've got stuff coming in. Family has failed her. There are trust issues. Gurmeet, thank you. In every dysfunctional family, child feels she needs to be accepted, and giving her body would buy her love and acceptance. Sexual trauma, extension of a wrong belief universally. There are trust issues. Parents are not supportive. ACEs, Kavita says. Kavita says physical trauma and emotional trauma. In case 10, the abuse was accepted as part and parcel of life, but sexual abuse followed by no support. So you see how the issues are compounded, how there is avoidance of social engagement for fear of revealing. This is lovely, my friends, because you are able to see the nuances of the mental health impact of this kind of trauma, perhaps even more elegantly than many people in my psychiatric fraternity do. My deepest appreciation. So I just wanted to do this exercise to give you, a sense of how finally how these children react to trauma at a developmental level. What was their pre-morbid functioning, their previous life experiences? Was it chronic? Was it one-off? How did the parents react? Was there any subsequent change in the living circumstances? And particularly for adolescents, in terms of anxiety, fearfulness, self-harm behaviors, aggressivity, sleep disturbance, gravitating towards high-risk behaviors, substance use, or sexual behaviors, expectations of maltreatment and abandonment, victimhood position, difficulties with trust, and the risk of re-victimization, especially if the adolescent has lived with chronic or complex trauma. So these are some books for your interest, treating complex trauma in their families, an integrative approach. John Brere, very well known, and this book resonates so well with what MKC presented in terms of family work. Hearing the internal trauma, working with adolescents who've been sexually abused, Sandra Wieland, this is part of the SAGE interpersonal violence series. And then there is treating trauma and traumatic grief in children and adolescents, Judith Cohen, Manarino, and Deblinger. Then there is, of course, relational trauma in infancy. There's treating risky and compulsive behavior in trauma survivors, again by John Brere. There is the trauma-informed socio-emotional toolbox for children and adolescents, a toolbox which you may consider keeping in your consultation chambers to assist you in doing very simple, elegant, and effective work with the adolescents who come to you. With this, I come to the end of part one of my presentation. And I would be happy to spend about 10 minutes before I go to part two to take any questions that you may want to put on chat on what we have discussed so far. I'll take about 3 to 5 questions, and then we will move to part two, and then we will break for lunch from 1 to 2 and reconvene at 2 o'clock for the remaining part of the session.
Harish sir, you can take the questions.
Take your time, friends, as you're as you're formulating your responses to.
So one of
Go ahead.
Yeah, let me just read the questions. They are actually comments only, no questions right now.
Right. I have seen the comments. Thank you very much for that. So let's.
So there's one question. 4-year-old girl child showing aggressive behavior at home. These have started from 2 to 3 months and include changing clothes if getting wet when even slightest crying loudly on telling us softly good or bad, and now holding urine for many hours. So
I'm aware that
not question actually, just comment only, sir. There are comments only, no questions, sir.
Yeah.
So one question I would like to ask.
Question in the chat box, actually. Sorry to interrupt you, ma'am. There is a question.
I could not see question. Is it necessary to immediately refer such children exposed to trauma to mental health professional? This is the question.
I would like to actually, I'd like to relate that question to the point that Jagdish Chinnappa has also made, that a general pediatrician can only suspect trauma-related symptoms, and formal assessment and treatment referral is a challenge in most places. So essentially, if you have an index of suspicion, on the basis of which you also see that the impact, which is why I've started with trauma impact, and you find that the trauma impact is quite severe, that the child is missing school, there are relationship issues, there are sleep and appetite disturbances, then obviously the severity, or the child is dissociating, then obviously the severity of the trauma is such that you would need expert assessment. And that's the point that Jagdish Chinnappa is making, that formal assessment and referral would be required, and which is why, as practicing pediatricians, in your network of professionals, if you know people who you can refer to, just as MKC referred to the point that there must be, if there is a family therapist, a psychologist working along with you, it would be useful. Or if there is a tertiary center to whom you can send such people for formal assessment. And of course, the
Yes,
point.
question, sir. What is a common presentation of abuse in adolescent, internalizing or externalizing?
Both, both,
Okay.
both equally.
Or does
And
the kind of trauma or abuse influence the resulting behavior?
the impact of trauma and abuse does not follow logical patterns. And therefore, one looks for both internalizing and externalizing. So that's what we mean by an index of suspicion. If a child is continuously aggressive, externalizing towards a particular individual, but not to others, that is very telling. Or if a child is continuously withdrawn and weeping and talking about guilt and shame, internalizing, that's also very telling. So you really look at the phenomenology of the internalizing and externalizing behavior to reach a level or an index of suspicion that you're dealing with, with a kind of trauma symptoms. I know that people have asked for trauma-related symptom checklist. I will refer that to Preeti. We have access to impact of trauma scale as well as trauma, kind of checklist, which we will make available to you.
Okay, sir. So there is a question: is it possible to work on the belief system of the adolescent, just like Alisha, that this violence is the kind of part of love?
No, this is something that happens in codependency. We see this in many marital relationships, as well, where violence is legitimized and presented as a manifestation of connection. But this is a belief that one must collectively argue against, because no violence can be justified in that sense. प्यार करता है इसीलिए मारता है, he loves you, which is why he hits you, is in a very gendered patriarchal kind of sense, is a completely unacceptable explanation, because it legitimizes violence and then couches it in the language of relationship and love, and one must argue against this. So thank you
But then
very
उनके
much.
belief system को change कैसे करेंगे सर?
Any belief system is dealt with in the context of a counseling relationship.
CBT में
It's where no, it's not about any particular technique. It goes beyond CBT to really examining what people's ideology about relationship is, and what do you believe are the manifestations of a good relationship in terms of shared hopes, communication, about love, about companionship, about joint activity, about joint time, about shared ideology on lives, about how daily life is being led with, and so on. I also see that.
There's one question, sir. One more question.
Kavita, if you don't interrupt me, please.
Sure.
Yeah, because I'm reading the chat. I'm quite
Okay,
alert.
okay, sir. Okay, I was
Because,
reading.
yeah. So I'm quite aware that there are a lot of comments on chat really looking at the whole issue of identity and the impact of films, particularly on toxic masculinity. And so, Kavita, to come back to your question, how do you address it? Is it CBT? To address the question that you asked, in fact, the way we do it in Samvad is we use films. We sit with adolescents and watch films that show relationships in their different light, and we follow the intent, content, methodology, and process paradigm. The intent is to address these belief systems. The content is toxic masculinity or violence and love. The methodology is films. And the therapeutic transformation occurs by then following the watching of the film, by a discussion with the adolescent. What did you think of this character? Why did she respond in this way? What else could he have done? What was he thinking? What was she thinking? Why did the family not intervene? What do you think is an ideal situation here? What would you do if you were in such a place? That's the way, Kavita, that we get into the question that you put of how to look at this transformation from a counseling perspective. I also see that Shobana has put a very large, a very detailed sort of case scenario about a 14-year-old girl with parents having suspected cognitive challenges, seen by the school pediatrician and found to have unexplained bruises. And the girl herself has moderate intellectual disability and was referred on mother's suspicion of CSA and request for psychiatric opinion. And the girl completely denies or does not express any abuse story. And the psychiatrists and external pediatricians are both unable to take this forward and attribute the mother's suspicion to the mother's own mental health. How does one protect this child? There are two issues here, Shobna. One is the protection issue and one is the history issue. In fact, if you remember when I said in the beginning of my talk that on 28th and 29th September in the Honorable Supreme Court, the JJ consultation is being held, and this consultation is entirely on JJ Act, POCSO, and children with disability. I also want to let you all know, friends, that when the Muzaffarpur case took place, and there were 47 girls in a childcare institution, and we were called to assist the CBI in the investigation. Many girls there had intellectual disability. So evidence gathering from children with intellectual disability is an entirely different skill. We have a lot of material pertaining to that. I will request Preeti to access that material from Samvad and make it available to you so that you know with a child who has intellectual disability, but if it is mild or even moderate, in severe or profound, just as with very young children, if there is no medical evidence, there is no eyewitness, and there is no confession, sometimes it's very difficult to, but if there is physical evidence of bruises, you know that an injury has taken place. Is it self-inflicted? Is it a fall? Or is it through physical abuse is what you have to really figure out. So this needs to be done essentially through a skill building process, which we have available. One part is this, the other part is basically part of protection. And so in the context of protection, if you really read the comment that Kavita has put on chat, which is if the abuse is intrafamilial and it is chronic, but the child does not perceive it as abuse, a lot of that really depends on the child, because children are used to hierarchy. And they believe that all parents hit or all parents scold. So this is how violence is kind of legitimized. And and this is not to vilify the parents, to say that your father and mother are horrible people, and because you're creating ambiguity and conflict. So this is a very nuanced approach where, in order, as Kavita points out, for this child in her 20s, in her 30s, not to get into damaging relationships or not to get into high-risk sexual behaviors, as Kavita has further qualified, to really look at the frame of reference I'd used earlier, happy, healthy, sexual decision making. And all these life skills are given in the manual that Kavita has already made available to you in the previous. So if you look at all these modules, that's the way you'll work in your clinic with children who have experiences of abuse. So thank you very much for your attention. Thank you, Kavita, for curating all of this and also nuancing it with some of the ideas. This really brings the session alive. Let's then go to the next part. And let me go to screen share, if I can. And I have spoken about the experience and the impact. Um, and let's look at family and system responses. That would be uh, a good place to go for the next. In your practice, if you, as we have understood now, the significance of a multidisciplinary response and systemic intervention, thanks to the many comments, Jagdish Chinnapa's comments of when to refer, who to refer to, thanks to the story that Shobna actually put, thanks to what Kavita actually put on chat to give yet another example. If you were to outline a broad family and systems response to be provided in CSA cases and a method of facilitating convergence of different systemic approaches, what we need to keep in mind is to divide it between medical interventions on the one hand. So, how do you prepare a child for medical interventions? Now, here are some scripts. We want to ensure that your health is all right. So, what do you tell them? And when children have been in unsafe circumstances or have been hurt or abused, they may acquire some infections. Treatment will help us identify if the infection is present and we can start treatment fast. Or, unprotected activity, sexual activity with known or unknown person can result in injury or disease, especially as we don't know what infections these people have. We just need to do some tests to check for any possible infection so that we can treat. Let me predicate the rest of what I'm saying to a story. 16-year-old girl, single parent, through a child welfare committee order that is placed in an institution. Good institution, she's doing well. There are holidays, she's sent home. She's in a relationship with a 17, 18-year-old. The mother is very uncomfortable, anxious, fearful. She believes that they may be engaging in physical intimacy. She goes to not the CWC that placed her in the institution, because there are 3 CWCs, one for young children and children in institutions, one for girls and one for boys. She goes to the girls' child welfare committee and says, I'm afraid of this. The child welfare committee passes an order to place her in a state-run girls' institution. The girl protests to say, please, I'm already in a good institution. Don't put me here, but they do not agree. Because the mother has expressed concerns about physical, perhaps sexual intimacy. The girl is told, we need to take you for medical checkup tomorrow, be ready. The next day comes, the girl is told, change and come, we have to leave. Girl says, just give me a minute, I'll come. She goes inside and hangs herself. The system is guilty of culpable homicide. You did not prepare the girl to say you've been abused or hurt in some ways, or it's just that we want to ensure that your health is all right, as we did in the first case. Please be reassured that if there is nothing untoward, there are no infections, there's no pregnancy, you can be reassured and relieved. And we can look at your mother's concerns in the relationship separately. But if you don't do that and you don't prepare, the doctor may ask to examine your private parts, but there'll be a nurse there or a mother. It may be a little scary or uncomfortable. It's only, to check for a health problem, just in case there is a pregnancy. Don't worry about it. We are here to support you. So how do you prepare a child, really? So these scripts are necessary. for different kinds of medical tests and examination. Now, I'm going to rush through this because you know this already. ID, who's to be present in the room, the permission of the child, assent, consent, what physical symptoms does the child have, what is a forensic examination, is any specific forensic examination being done? Is the examination requested by the police for documenting abuse? Are swabs required? Is there a pregnancy test, a urine test? In case the results are false negative, does a gynec opinion, is a gynec opinion required? What if the child is 16 but under 20 weeks of pregnancy? About discussions on abortion, and so on and so forth. So I'm just giving you a frame of reference so that you're aware that these situations come to an adolescent practitioner's attention. If pregnant, what is the adolescent's wish or desire or need to go ahead? Help the adolescent reflect on her decision to have the child, pros and cons, financial, logistics, future. How will she explain to the child uh, uh, acceptance and non-acceptance of the future? And from the child rights perspective, if it is the adolescent's right to finally decide whether or not terminate the pregnancy, we have no right to impose our views and decision, as valid as those may be, and however well-intentioned they may be. So, what does a rights-based approach to adolescent practice actually mean? So, working with adolescent girls on pregnancy issues, given their adolescent brain physiology, impulsivity, emotionality, decision making, but it is still not your decision. So, how do you balance child rights and the child's best interest? You're non-judgmental. You acknowledge the desire to keep the child or not, future life plans, dreams, romance, education, finances. But what about safety? Where will this adolescent go? Home, relative, childcare institution? Where did the abuse take place? Who was the perpetrator? Was it a family member? Was it a stranger? Where will the adolescent be safe? Where will the adolescent feel safe? And what is her decision? So look at these case scenarios. Look at case 3, the same case that we'd spoken about earlier. If a 15-year-old girl who was sexually abused by her uncle lives in the same space as her family and they've come to you, how would you respond? What would your response be? Or a Jay who's a 14-year-old, let's leave the 10 and 13-year-old. If Jay is a 14-year-old, lives in a residential school, enjoys being in the hostel, went home for summer, was abused by the neighbor, returns to school, then she reports the abuse to the school counselor, who then brings the child to the local pediatrician. Or even take the 13-year-old case too, sexually abused by a sports coach during his football training practice. And then is brought to you complaining of stomach ache, but actually there is no problem in the stomach. But you find out on further inquiry that did anything happen before the stomach ache started, or did anything else happen before you started having pain during defecation or something like that? And then the child discloses this is what happened. How do you respond to each of these cases? Now, I know that given the limitations of a webinar like this, skill building and training is not part of this webinar, but to be able to develop a script becomes important, because look at what happens with pain, memory, trauma, healing, and so on.
The time period that I'm talking about, the time period of abuse, was between the ages of 9 to 13. So I remember how it started. Like, I remember the exact moment. I don't remember exactly how old I was, but this person who did it for the longest time, he was you could call him a family friend. Like he was my aunt's husband's, I don't know, nephew or something, and he was someone from their side. So it was a very distant relative. And he used to spend a lot of time at our house. I remember distinctly that there was some time when he came home, and I just hugged him because he got me a chocolate or something, and it was a very innocent hug. And I remember later in the same day is when it started. My father passed away when I was 11, and about a year and a half before that, he had a very massive attack. He was a lung patient and he had a lung disease and he had a very bad attack, so much so that um, at that point, actually, we had thought that we would probably lose him. So he was in the hospital for a long period of time, at which point I was alone at home um, for most of the time because my brother at that point was not at home and he was outside studying engineering. So my mother would be at the hospital and I'll be alone at home, and this guy would come home on the pretext of seeing me, and then it would just happen. Like he would touch me all over, he would grope me, he would rub himself against me, and from time to time he would ask me, I do this. I hope you don't mind, right? আমি তোমাকে আদর করছি. This is a way of showing my love. In the time when my father had this major attack, and in the time of recovery after he came back from the hospital, also, I was staying for a long time with my aunt and uncle. This guy also used to stay with them many times. Many a times they would leave me alone with him, like leave him to babysit me. And there was a free pass for him to do anything that he wanted to do. I remember I used to try and avoid him. Like if he was sitting on the bed, I would sit on the floor. Eventually, I don't know, I don't remember exactly how it stopped, but he kind of phased out of my life. I mean, I remember just feeling at that point that there was so much happening on my father's end, and there was so much that my mother was going through anyway. So I just felt like the fact that this was happening to me and that I did not particularly like it was not something that I should have articulated. Later, I figured out that maybe I should have probably said that to them, because that, I have a feeling, to a certain extent festered. I would blame my mother or my brother, who's 11 years older to me, for not paying enough attention or knowing their child enough to figure out that something was wrong. That feeling has long gone. It has gone, of course, with a certain amount of therapy. Funnily enough, I mean, if I had to, I can't even properly recall his entire face. But there are times when I think about it and I can just feel my body feeling the same touch again. I mean, I don't know how to explain it. It's just, I can feel that feeling that I felt at that point in time. That is something that's really difficult to shake off. I have never thought of approaching this legally at all, because this perpetrator kind of left my life without me actually doing anything. It was a gradual process. And secondly, after a certain point in time, it really stopped mattering who the person who was doing it was. Like right now, honestly, it doesn't matter to me whether that guy is brought to the book for my crime, because I just think it will bring up a lot of unpleasant memories if I go back, and it's just not something that I want to get deep into at this point in time, because the repercussions, I honestly think I don't have the strength to deal with right now. But what I had a problem with was that I felt that my family should pay for it for not protecting me, and that is something that I have worked with, and that is something that I would much rather, if I had to work on something, that is what I would work on, rather than getting some kind of legal retribution. I think because of the incident, since my teenage life and all through my adult life, I have stopped paying as much importance, or assigning as much importance to sex or sexual activities as I think a lot of people do. There's a certain kind of sacredness that certain people assign to sex, which I have never assigned. That has led me to be the victim of slut shaming. That has led to a lot of misunderstandings. That has led to a lot of mental harassment and heartbreak for different reasons. But yeah, like I am what people colloquially would call sexually easy, quote unquote. There have been multiple incidents in multiple other places by multiple other people, but this is really what I would say has stayed on and will stay on for the rest of my life.
तो ये है friends, this whole internalization, as thinking practitioners, I believe that most of you who have chosen to be part of the Adolescent Health Academy of IAP think of yourselves remarkably in my estimation and in my esteem as people who have gone beyond the medical model of diseases and prescriptions to actually looking at lives and looking at people in their struggle for identity. So to cap this session before we break for lunch, how children look at how Ishadrita has internalized. How did she internalize? How did her caretaker response? The non-offending caretakers. What do you do with parents who have a child who has survived while caring for the child and protecting them? There are systems involved, police, investigations, family dynamics, and non-offending carers often need their own psychological support. And so how do you as practitioners keep all this in mind? So basically, the distress of the child, the emotional distress of the parent in response to the abuse, the distress of the child creating new parenting challenges, parents managing distress of self and the child, compromised parental support of the child, impact on the child's resilience recovery, further strain on parents. And you can see how the cycle sort of goes on. And to be cognizant of this, acknowledge and recognize it to parents so that they feel understood. So what you tell parents is the importance of belief immediately post disclosure and in long term, that it's very important for positive outcome. How to address potential problematic sexual behaviors, changes in living arrangements to prevent reoffending if the perpetrator is intrafamilial, to recognize PTSD. You remember the point that Jagdish Chandappa made. When, how, and who do we refer to? So when you look at symptoms of PTSD or self-harm and things like that, or emotional states where routine activities are affected, this are your indications for referral. And if the perpetrator is biologically related and there's a lot of denial, how do you educate them about the behavior of offenders and how could he do this, or he cannot be doing this and she cannot be doing this? So belief is a precursor to many mandatory reporting and legal interventions to keep in mind. So basically, tell parents, do not ignore or undermine a child's statement. Believe what the child tells you. Do not blame the child. Tell the child that it was not the child's fault. Do not, please don't blame the parents for not being vigilant or alert enough. And remember, grooming, all abuse is not necessarily coercive or violent. It can be very cleverly planned. So if you show openness to the child when you want to tell me about what happened, how you feel about it, I'm ready to listen. Regularize routine, because predictability and routine and normalization of routine is very important. And remember what I said about emotional regulation, journaling, drawing, imagery, relaxation, music, dance, reclamation of routine without trivializing the abuse. and discussion on how to report emergency medical services if required, particularly there's been penetrative intercourse, counseling from mental health professionals as indicated, and encouraging parents to be balanced in care after CSA because overprotection is not desirable. So this is what I wanted to share, and I will take the next 10 or 15 minutes in addressing issues that you put on chat, and we'll break at 1 and reassemble at 2 o'clock. I do note that there is a further reduction of numbers, Kavita, but that's all right. The fact that 96 people are still there, the fact that MKC is still there is a sign of great encouragement to me. The fact that Kiran Agarwal is still there, Kiran is a dear friend and such a champion like MKC of child rights, of child safety, and indeed, a lot of the people, Preeti included, such champions of the academy.
Can I interfere 1 minute?
It is not an interference at all.
Yeah, the story that girl said actually left it without explanation. If you can summarize what is the mental process the child was going through and what is her status now, it will help everybody, all the participants. Just in small words, not detail.
Yeah. So the issue, MKC and friends, is very simple to summarize. If you look at the impact of abuse in terms of the traumagenic dynamics, traumatic sexualization, betrayal, powerlessness, and stigmatization.
Yeah.
Traumatic sexualization does not necessarily mean coercion, hurt, and injury. It also means exposing through grooming a child to sexual activity that the child is not prepared for. Hence, in adult outcome, no wonder adult outcome can either be phobic avoidance of sexuality because it was hurtful, traumatic injury, hospitalization, or high-risk behaviors because you were sexualized. Now, so if you look at betrayal, either there'll be mistrust, aggressive relationships, or it'll be getting into damaging relationships and trusting people too easily because you're clinging on to. So the same experience can give rise to diametrically opposite adult outcomes. That's the point she made when she says that having been sexualized from age 9, your mind gets constructed that you don't relate sexuality to something sacred only in a heterosexual context to marriage and to monogamy and so on, and then you're labeled as easy and you're slut shamed. Whereas you're actually a vibrant woman who does not equate sexuality in the context of. So, how your sexuality ideology actually develops is the point that she's making. So, the same experience can give rise to diametrically opposite reactions. So, I'm now essentially scrolling through chat with the blessings of. There's something wrong with my cursor. Are you able to hear me? Can someone tell me if you're able to hear me?
Yeah, we can hear you, but your video is frozen.
I see. Let me try and rectify this. I'll try and re-log in later, but if you can hear me, if Kavita, now I would really need your assistance.
Sure, sir. Sure, sir.
I can hear Kavita's inner voice. अच्छा, अब हमसे मदद मांगोगे?
No, sir, not at all.
No. if you can just curate about
Sir,
two or
sir. Dr. Satish Pandya says that does the story narrated mean that CSA child become more vulnerable in later life?
Yes and no. Yes and no. Yes, because if left untreated, they develop their own notions about relationships, about body integrity, about sexual decision making, and the likelihood, therefore, of not experiencing a happy, healthy, safe, and responsible sexuality is much more. No, it need not need to lead to it. For any trauma, uh, actually, Satish, for any trauma, it is said that the earlier you intervene, it's like any medical disease. The earlier you intervene, the better. If any medical disease left untreated, you know what happens. It becomes diabetes left untreated, neuropathy, and then diabetic nephropathy, and so on, gangrene. So the dictum in trauma is the earlier you intervene, the better it is, and you will actually mitigate later vulnerabilities in life because you've addressed many of the basic vulnerabilities that got contextualized when children were actually abused. Kavita, next.
Yes, sir. So you mentioned that a 16-year-old girl who is pregnant has a choice in terminating. Does her assent override parental consent?
It's a tricky balance, to kind of a lot depends. Like I said, this needs to be seen in the light of the current climate as far as consenting adolescent relationships are concerned. If the pregnancy has occurred due to a sexual assault by an unknown person, it means one thing. If it has occurred in the context of a loving and consenting relationship, it means something else. And this is where the point that MKC made about the difference between family therapy and family-based practice. Now, families will obviously say, no way are you going to keep this child, no way are you going to be with this person. Whereas the Vidhi report, and if Preeti can also sort of give you all a summary of the Vidhi report on an analysis of the POCSO cases, which looks at the number where there is actually consenting and loving adolescent relationships. How do you advocate for the child as a professional to say, we understand your concern and your anguish and your anger that your 16-year-old is pregnant? I mean, what the hell? How can this even be acceptable kind of thing? But let's look at it in perspective and then see how to proceed.
Okay, sir. So next is actually my question only. I had actually few cases at my clinic, girls from suffering from depression and on detailed history. I came to know that they had like brother या cousin या मामा ने उनके साथ sexual abuse किया था in the childhood, which they could never share with anyone. And in fact, if they'll share, the parents will not believe on it. अब how do I handle this girl? अब क्योंकि वो relationships उस family में है, she belongs to the relationships, तो अभी उसको कैसे deal करना है? That's my question actually.
I think, Kavita, we lost Dr. Shekhar because
I think he'll rejoin.
Net connection. Yeah.
Maybe he'll rejoin.
Yeah. Call him up. Otherwise, we can take up this after the break. Just call him up once. Yeah.
I think we can take after the break.
Yes, sir.
Yes, sir. We'll do that, sir.
Let me confirm him from sir. He's not receiving. Maybe let us wait for a few minutes, else we'll. MKC, sir, your say on such cases?
When Big Boss is there, I should not make comments.
Okay.
I think the top priority, somebody's asked what to deal with it. The top priority is to keep the child safe. So the best interest of the child's safety is to be given prominence over any other aspect. So if the perpetrator is at home, shift the child out. You can shift the child out to a grandparent's house. You may even shift the child out to a hostel, right? So we have to keep the child safe at any cost. Yes, the mandatory reporting and all has to be done, but the child's safety is of paramount importance. We cannot afford that the child should keep on getting abused again and again. So that's very clear.
Why I don't want to make comment is, let's not, disturb the flow of thought.
Yes, sir. I'm just speaking on his behalf because I've attended almost
Yeah.
a number of his classes.
Everybody has their own style of saying.
Yes,
So let him
sir.
answer that. That's much
Yeah,
better.
exactly, sir. Just kind of re-emphasizing safety is to be given
Big
paramount.
boss is sitting there, Sita Raman. Namaste.
Yes.
Sita Raman, sir. Namaste. Come from MKC.
Yeah, sorry.
Yes.
You're back.
I had an access situation, some tech issue, but it's been rectified. So I missed a bit was what was happening. Preeti, can you give me a summary of what the basic context was and your response, and I'll cap it, and then we'll end this.
So what Kavita was asking was that if a context was to be has taken place, the abuse has taken place in the context of a family situation, like there's somebody in the family who is doing the abuse, how do we counsel and help these children?
Okay, no, so let's look at several streams of response. You see, incest abuse and intrafamilial abuse is a very complex issue. Because there'll be denial, there'll be all kinds of turmoil taking place in the family, particularly if the perpetrator is in a position of power in the family, either financially or in terms of decision making. The first priority is to prevent reoffending. So we need an ally in the family. It could be a grandmother, it could be a distant relative, and we need to make a strategy where the perpetrator is not in contact with the child. That's the first priority. The second priority is to really look at the emotional state of the child after you've seen if there's any emergency medical issues to be dealt with. So if the abuse has been penetrative, then you go into a completely different protocol of response. Whereas, so please remember, non-contact, contact. In contact, non-genital, genital. In genital, non-penetrative, penetrative. In penetrative, non-assaultative, assaultative. This is important from a medical viewpoint. It's important from POCSO and legal viewpoint also, because the quantum of punishment varies. So, prevent reoffending, priority number one. Prevent access of the perpetrator to the child. Number two, look at protocols of response based on emergency, medical, psychological. Number three, look at the immediate needs of the child and your first level responses. Preparing the family, working with the family to deal with what's happened to the child and the conflict and confusion of who the perpetrator is, because in this case, it's intrafamilial. Then to maintain the routine of the child will say, I don't want to go to school. How can I go to school? And so on. So how do you maintain so that, remember the slide I presented about the interruption in the developmental trajectory? Life comes to a stop. Don't talk to anyone. Don't go to school. Everything comes to a stop. Your life then becomes circumscribed to pediatricians, gynecologists, forensic people, police, courts, and so on. This is not normal for a 14-year-old or a 16-year-old. So, and all this will go on. You cannot prevent it. But how do you keep the normal track also going to say that it's your entitlement and right? So there's a whole sequence of events and a protocol that we follow, all of which is kind of available. So I see that there are many other issues that have been put in. I see that Jaipal Kapoor is asking about building the strength and adolescent to tide of the crisis. Jaipal, I will be referring to this in the post-lunch session. Also, how to break the vicious cycle of effect on the family and the child. I've alluded to it partly in terms of the scripts that you have for the family, but I'll cap this when we reconvene post-lunch. So with the permission of the organizers, we'll take a lunch break from 1 to 2.
Yes, sir.
Yes, sir.
We'll
Wonderful.
reconvene at 2 and I'll look at the remaining
2
part
o'clock,
of
yeah.
the
We'll
presentation.
rejoin on at 2 o'clock.
2 o'clock.
Yes, sir.
So just wanted to appreciate that.
So what happens?
I just want to appreciate the sessions.
Yeah, Kavita, do people?
Dr. Himabindu here from Hyderabad, the next president for the 2025 AHA. Very happy that Kavita and Preeti and all of you are doing such sessions. Sheshadri sir, I attended
Thank
all
you.
of your sessions early. It's always a very good experience, and we look forward for a special program maybe for the youth in the next year under your guidance.
Chala bagundi, madam. Chala bagundi.
Thank you, sir.
Thank you, sir.
So,
Thank you. Thank you.
Kavita, what happens? Do we log off and re-log in, or we stay logged in?
So stay logged in or relog in, that both way it will come.
Doesn't
I have
matter.
asked him to prepare recording in 2 hours. So whether
Yeah.
you stay or you just leave, that is okay.
Yeah.
Both ways it is okay.
Yeah. Dr. Anita, I've also noted your thing about incident happened in the past and the adolescent discusses now. I'll tell you about this because it has a time thing and it depends on when the incident took place. 2012 is a very critical year. I'll tell you why when I come back at 2 o'clock. Have a good lunch. Keep it as a working lunch. Don't eat too much of rice and ghee and papu and sabji so that you fall off asleep.
Okay, sir. Thank you. Thank you. Let's rejoin again.
Yeah,
Meet
all
at
right.
2. Thank you. Thank you.
Thank you. Bye-bye.
Dr. Kavita, my question is unanswered. I hope that will be taken in the post lunch.
Yes, ma'am. I've already written it in my paper. I'll definitely take it.
Thank you. Thank you.
Yes.
So far have been informative and engaging and helpful, perhaps in your chamber practice. We are at the current point of time down to a count of 57. We started with 134. Some attrition does take place in more, and I believe that about a 50 to 60% attrition is the norm. And I think we're doing quite well. We are upwards of that. And great credit to Kavita's organization, Preeti, everyone in the Adolescent Health Academy who've been involved in the issue. I know that people would like to meet me. I've noted Jagdish's request. Before we start the session, I just wanted to tell you all, I retired 3 years ago. When I was in service, I used to work about 7-8 hours a day. After I work about 14 to 16 hours a day, and I have insane travel, and it would interest people in Bangalore like Preeti and Jagdish to know that mostly in Bangalore to put a load in the washing machine. I have absolutely insane travel. And as I said, because the Supreme Court consultation is on 28th, 29th September, I'm actually leaving for Delhi in the coming week, also to get a meeting with the new Minister of Women and Child Development, Annapurna Devi, who's from Jharkhand, and also with the Secretary to look at the future of Samvad, after which I'm leaving for Nepal to attend the conference of Child and Adolescent South Asia Mental Health Network that I have set up to support Pakistan, Afghanistan, Nepal, Bhutan, Bangladesh, Sri Lanka, and Maldives. So I'm presenting my public child mental health work with the focus on child mental health and justice and perspectives from South Asia, how different countries look at child protection, and the whole transdisciplinary approach that Samvad believes in, which is teaching child protection systems about mental health, teaching mental health people about child protection, working with pediatricians in learning exercises to, for forensic child psychiatry, which is, hardly ever taught, as we all know, both in our MD pediatrics as well as in MD psychiatry. So that's the kind of work that I'm doing now. So I'll certainly be in touch, Jagdish, and you can just be on touch with me on WhatsApp, and whenever I am in town, I'd be honored and privileged to meet you again and chat on some of our very common interests and activities where children are concerned that we jointly believe in. Let's start the afternoon session with a couple of questions that Kavita has curated, and then I will sort of segue into the last two portions of the presentation. Kavita, over to you.
Yes, I have sorted out a few questions. This is a question from Dr. Himabindu ma'am. How to deal with night terrors following any trauma like loss of family member or sibling, etc.?
Well, a couple of quick responses. The issue of night terrors per se may not be within the purview of this webinar, but since Dr. Singh has clearly located it in the context of trauma and night terrors. See, there's a difference between nightmares and night terrors. So I presume that in the aftermath of trauma, what often happens is if the conflict and insecurities related to trauma have not been successfully resolved, they continue to reside both in the conscious and the subconscious, and spill over perhaps in bad dreams and nightmares that you have, and you wake up in cold sweat, and you wake up with these horrible, terrible dreams. Now, if an adolescent were to report nightmares, sleep disturbance in a frightened state of mind, and we have a background history of trauma, and the content of the dream either directly or indirectly represents the nature of traumatic experiences. Like I said, these may not be direct, they may be indirect. Then the first thing that is done is to make the link. I'll tell you why. The problem with the PTSD model is that it often pathologizes symptoms. Whereas my submission to you is a lot of these symptoms are normal responses to an abnormal situation. What happened was abnormal. And how do you expect a child or an adolescent to react to an abnormal situation with equanimity and equipoise when even the best of us cannot respond in that way to challenges that we endure in our lives? So, first of all, to make the connection to say these things happen, and what was abnormal was the trauma that you endured, and this is the consequence of that. And there are very many means by which you can reduce the frequency, the intensity, the content of these dreams. And that's where we do all the relaxation work, the diary maintaining. Then we also do a lot of sleep hygiene work. Before going to sleep, you get into doing certain exercises. It could be yoga nidra, it could be imagery exercises, it could be doing something that you like, listening to music that you like, writing a new poem on narratives of hope, so that you go to sleep in a frame of mind where you're not carrying the rumination of what you had endured and experienced. And over a period of time, then, the sleep patterns you kind of revert, and then you may still continue to have disturbed sleeps or nightmares now and then, but at least the frequency and intensity comes down. So that's the way that one would really approach it. Kavita?
Okay. So next question is, every child faces one or another trauma during childhood. and certainly not easy for we as parents. So, what we as parents should do to minimize trauma?
Uh, you know, one has often wondered, um, and you know, it's a very interesting question, Kavita, because it has great political connotations, and I'll tell you why. I have been struggling in the last 2.5 years. Samvad is in its fifth year of operation. We were in principle supported for 5 years, and we are trying to convert it from project mode to center mode. And the reason for that, friends, is child protection is not like smallpox or polio. It will never be eradicated. ये कठोर और सत्य है, कड़वा सत्य है ये. You know, this is a bitter truth of the terrible nature of humankind. Exploitation is our default mode, you know, preying on the vulnerable. बड़े अफसोस की बात है ये. So, therefore, we believe that response is equal to prevention is equal to response. And if, therefore, we build a parent-child relationship which is based on a culture of conversations and not on a culture of instruction, expectation, control, and obedience. Even things that happen, which may not be abuse, but small consternation of life, for the child to say, Papa, you know what happened today? There was this road rage and they were hitting each other, Papa. And the mothers, and the father responds because the child is in agitation because he's seen this horrible act of violence. So, and if someone misbehaves or someone bullies you or if someone is aggressive, to be able to come and report, and then you respond to it, you know, with validation, and then you add to it the kind of life skills work that we do. So all our prevention modules, both for the 13 to 18-year-old, as well as the young, the 7 to 13, plus with preschoolers and children with disability. Now, this brings me, Kavita, to a point that you had made initially जब हमारे आज के सत्र में बात हुई थी. See, you used the word safe and unsafe touch. If you recall, when you let me tell you, Samvad is completely against this paradigm. I'll tell you why. Adult women like you and Preeti know what a safe and unsafe touch is. It will not prevent motivated people from misbehaving with you. तो आपका उस जानने का फायदा क्या है अगर कोई बदतमीज कमीना आप you know if he wants to misbehave, it is not going to prevent. Secondly, the often when grooming takes place, this so-called bad, sorry, not safe and unsafe, the good and bad, the so-called bad touch, even safe and unsafe, I have a problem. The so-called bad touch feels good because no one is forcing you. ये तो seduction, you know, all this seduction and, you know, and the body learns to respond. Remember what the lady said in the video. You know, the sacredness of sex, you know, has gone. So to me, you know, it was just a pleasurable activity. And I do not believe in the legitimacy of sex in the context of this heterosexual institution of marriage. I mean, that's and people who do not believe in that are not bad or immoral. We have no right to judge in that sense. So these are complex and abstract issues that one has to, you know, wrap one's head around. So you cannot put the onus on a young child, particularly, to be able to make out all this bad, good, safe, unsafe, and all that. You have to create systems of response which keep perpetrators on the alert. कि this culture of impunity जो होता है ना, कि nobody will know, or you know, I will deny, people will not report. You know, cases go on for very long. In any case, you know, this is called the culture of impunity. The fact that you can get away with. So the more you strengthen your systems and show that your response is quick, it is incisive, and it is non-negotiable and uncompromising, in its focus on child protection that people will say, let me think twice before even considering, trying to hit on a child or hit on an adolescent. So that's the way that we build a culture of conversations and a protective system. And this is what Samvad is trying to do when we work with judges and we work with the police and the judiciary and child protection. To understand what trauma means. I mean, imagine the predicament of a child who's been trafficked and rescued after 8 months and through a child welfare committee order put in a childcare institution, and then she's cutting herself or is silent and weeping, and the well-meaning staff says, "Ki, ab kya hua? Bacha liya na? You've been rescued. No, what is the problem now? Boss, you don't know what she has endured." If you have any idea of what happens in a sex work location, the brutal reality, why will she not cut herself unless you validate the anger that she carries, particularly if she's been trafficked with complicity of the family? And look at the question in her mind. Did I not have value for my family? My only value was in the money that I brought them? Or horrible still, my only value was between my legs? मेरी और कोई वैल्यू नहीं थी. And so can you imagine what it means to be devalued and converted to an object for financial considerations, to be exploited by essentially, the demand supply sector? So we often say that, the trafficking sector, Kavita, they are clever. वो बड़े चालाक हैं. And if your rescue and your police systems are not equally clever and well organized, it's a losing battle. You cannot imagine how well networked and clever the trafficking system is. So the best way to protect children is by maintaining a culture of conversation, ताकि वो बेझिझक, निसंकोच, without any inhibition, they will come and speak to you.
Sir, a question from Dr. Kiran. I get communication with adults getting abused with the family. Can I, means a doctor can lodge a complaint under POCSO?
Yeah, so this is something that I wanted to address. Friends, a law does not operate in retrospect. POCSO came into existence in 2012. If an act of abuse on a child under the age of 18 occurred after 2012, you can lodge a complaint under POCSO. But if it occurred before 2012, the law does not hold. If, let's say, somebody was 14 years old in 2013 and was abused then, we are in 2024 now, she's 25 years old now, she can still lodge a complaint. So there is no time period which says कि अरे यार 10 साल निकल गया, there's nothing like that. Provided you were a child as defined by the law under the age of 18 in 2012 and the abuse occurred after 2012, whatever your age is now, you can still lodge a complaint.
So that's the doctor can complain or not?
Anyone can.
Anyone can. Okay.
Anyone can.
Sir, this is actually your comments is required. As general pediatrician, we can suspect trauma-related symptoms. Formal assessment and treatment and referrals are really challenging for pediatricians.
Yeah, no, Jagdish had put that comment. It was in reference to that I said that if you recognize levels of severity of trauma impact in terms of functioning, sleep appetite disturbances, suicidality, depression, high-risk behaviors, those are your indicators that this is beyond the scope of a general pediatrician and you need the assistance of a mental health professional to be able to deal with complexity. And the question that Anupama has put, I actually already addressed this. Perhaps I'll just repeat that. And in fact, you see, it's like this. If someone has undergone trauma of sexual abuse, Anupama, friends, and in your therapeutic work, you take care to ensure that aspects of identity are recognized and nurtured so that the trauma of abuse does not form the entirety of his or her identity. So, the worst thing that an activist can do is to make the child believe that my experience of sexual abuse is the single most important event of my life that I should not forget for the rest of my life, and that defines who I am in entirety. You're much more than that. And therefore, in the exit counseling, in the perception or the experience of identity, dirty, different, damaged, and so on, to say that is one aspect of what happened to you, understandably and acknowledgedly difficult, but it doesn't define who you are. You're much more than that. And that's what we build, which is why we've shifted from PTSD to trauma-informed care, and from trauma-informed care to healing-centered engagement. And healing-centered engagement means हम नजरअंदाज नहीं कर रहे हैं सदमे को. We are not trivializing what happened. We recognize its seriousness. We recognize its impact. But we believe, and we would like you to believe, rightly so, that you're much more than an abuse survivor. And there are many aspects of identity. So that's called reclamation. And I will refer to a bit of that as I go into the next part of my presentation with your kind permission and Ashirwad,
Yes, sir, we
Kavita.
can go ahead for next. Sir, please.
Okay,
We
so
can
with
go ahead.
Kavita's permission and Ashirwad, I'm going on to. Thank you. So when we speak of healing and recovery interventions for sexually abused children, what we need to keep in mind, let's take it sequentially. I keep referring to the whole issue of first level responses to child sexual abuse. So here's what you need to keep in mind. What kind of psychosocial intervention in the immediate aftermath to prevent further mental health morbidity? What kind of responses can you have to children's initial confusions and queries about the experience? And what are the kind of techniques and activities that help in the initiation of the process of recovery and healing? So, what initial psychological sort of work entails, response entails, is reassurance about safety and about help. But the child may be in a state of agitation, and therefore containment techniques, suppressing bothersome feelings and memories. So when the child is too overwhelmed and extreme levels of anxiety, so relaxation, recreation, family support, reassurance, meeting developmental needs, all this provide a scaffolding for the arousal, the agitation, and escalating anxiety to get control. To say, I'm teaching you all this so that this tension gets contained, and then we'll be able to better deal with many of the questions you have in your mind, and I'll be happy to address them for you. Then comes the whole issue of the inner voice framework. So let's say a child comes from a single parent family, or a child comes from a family where there's relative neglect and undergoes an abuse experience. Now, obviously, the child is thinking something at that point of time which generates anxiety, sadness, agitation, and it gives rise to various behaviors, bedwetting, aggression, cutting, and so on. If you use the inner voice framework and you look at this case, and let's look at Case number 2, a 15-year-old girl is suddenly doing poorly in academics and getting into arguments with her peers. When people get upset with her or ask her why she's behaving that way, she bursts into tears. One day, you call and gently ask what is troubling her. She tells you that her uncle, who visits her home regularly, comes into her room each night and touches her genitals. She also tells you later that her father's friend has touched her similarly once. Now, if you were to go back, we know what the issue, the context and the experiences. We know the context, and we know the behavior is also getting into arguments, doing poorly in academics, getting upset, crying, and so on. And we know what the context and the experiences of this uncle and someone else. But if you focus on the child's inner voice and thoughts and emotions, what would they be? Is the kind of questions that we ask. So, why is he doing this to me? Is it only me or everyone else? Is this normal? How should I feel about it? Who should I tell? Will they believe me? Will they blame me? You see how it's addressing this kind of inner voice that makes the difference of how the power of counseling actually gets established. So you look at all these cases, 16-year-old rescued from sex trafficking in a childcare institution, trafficked by her family, been in sex work for 2 years, angry, aggressive all the time, mistrustful of people, talks about revenge, at other times says her life is over since her self-respect has been taken away. What would she be thinking? What would she be feeling? We know what the behavior is. We know what the context is. But the most critical thing is, what is she thinking in her mind and what is she feeling? And this is why responding to children's inner voice, if you read each of these cases and you list these inner voices, confusions, questions that the child may have, and use the inner voices, the thoughts and questions you list in the child that you see next in your clinic, and attempt to provide a response to each of the questions on the list, what would you say to the child? Now, obviously, what you say depends on the age of the child. Is this a 6-year-old or a 16-year-old? It depends on the understanding of the child. There's a difference between a 14-year-old who was molested by a stranger as opposed to a 6-year-old whose cousin was just playing with her. How do you provide comfort without false reassurance and without misrepresentation of facts? So that's the kind of skill that's really necessary. There are other immediate interventions. I already alluded to them. There's relaxation, there's leisure, there's resumption of daily activities and developmental activities, there's identity exercises. And how we do relaxation, it could be breathing exercises and pranayama and deep breathing. It could be imagery exercises, and you can develop your own scripts. Close your eyes and relax in your chair. I'm going to teach you something when you're tense to do this exercise. It'll bring down the arousal so that some of the challenges that you deal with and difficult questions that you have, you'll be in a better state of mind to address it. Not to say that this imagery is magic. You do this imagery, everything will improve. That's not how it happens. So close your eyes and relax in your chair. Sit in a comfortable position. Take off your shoes. Relax your body. Think that you're floating among the clouds. You softly reach out and touch them. You feel the sunlight streaming through. So a lot of this kind of imagery exercises using nature and so on, which is of help to the. So why we use them? To feel better, to calm down, to reduce anxiety. When do we use them? When we feel anxiety arising. If you do not explain this, they will not understand why and when, and the activities will not work. And then you have to demonstrate and do it with them. Then there are leisure and fun activities. Developing a routine. Because, loss of routine and loss of predictability is very problematic for a child who's already experienced trauma. So to get at the child or the parents to organize daily self-care, school, play, recreation, family time, it restores normalcy and balance. It restores predictability. It enables the child to develop mastery, agency, and control and decision making, which has hitherto been taken away. And that's why we come to the identity. The question that was put, do they really, what happens to them? So look at these figures. If you look at figure A, if sexual abuse is the entire thing on identity, whereas sexual abuse identity is reduced in the overall identity, and there are other aspects to identity, such as role, talents, and interest. That's the kind of work that we do, because what happens due to CSA is that the child may see himself or herself as being weak, as helpless, and this spills over into other life situations. And that's why they say, I can't do it, I'm not good, I am equal to my abuse. So the whole notion of selfhood being colored by abuse. Whereas if the present and future decisions that stem from this identity, the world is a hostile space. I can never trust people. I don't want to get into any intimate relationship. And if you want to preserve a wholesome identity, this is the kind of work that we do. So these are some exercises that we do for selfhood. We explain the idea of identity. And then we could do various exercises like paper cutouts. Then this is you. We can divide the paper into three parts, different parts. For example, head, upper body, and lower body. So the head is a student, a family member, a citizen, a friend, uh, and then qualities and talents, things that you do with your hands, and so on. Then you discuss with the child that how identity is how you perceive yourself. And identity is not just what you don't manage to do, your worries, fears, but also what you can do and what you like to do and what you're good at doing. So these are all simple exercises for identity reclamation. These are all short term. Now, what happens in providing long term interventions is we are looking at long term recovery. Remember, high risk mistrust issues and so on. Let's have a look at this video and you have an idea what trauma-informed care means.
Understanding trauma is hard. The existing theoretical material can be extremely overwhelming. Even if you can manage the sheer volume of theoretical material on the subject, there is no knowing what would work in practice. This video focuses on the compilation of an interaction with my mentor on childhood trauma and its impact. Our interaction helped me gain perspective.
Sorry?
Understand how trauma can be approached better in practice. Where do I start? I think it helps if I use a case for discussion. This will help you understand the dynamics that come into play in practice. But before I share the case, I would like you to keep a few things in mind. Make a note that major traumatic events can change the way children perceive themselves and others and change the way they behave. Another thing that should be noted is that abuse, including sexual abuse, as just an important. Knowing about childhood trauma will help you to understand and respond appropriately to a child.
Sir, voice has gone.
Oh boy, I don't know. Now?
Still not, sir.
Let's take an example.
Yeah, now it's there.
Is a 9-year-old boy who you interact with at an NGO where the Child Welfare Committee has placed him. Your interaction with Nakul makes you realize that he knows very specific details about sexual intercourse, something that is not expected of a 9-year-old. During a subsequent meeting with Nakul, you find out that he was very close with his uncle. You're talking with him now, and he is telling you about how he is good at keeping secrets, like the one that stayed between him and his uncle. While telling you about the secret, the boy's voice drops. He stops making eye contact and he appears to withdraw.
Sir, again the voice has gone.
What do these signs indicate? Nakul is relieving his very frightening experience at the hands of a trusted member of the family and is likely feeling scared, help.
Let me see why this is happening.
Helpless and vulnerable. He is becoming distressed. Understanding trauma is hard.
Is this
The
better?
existing theoretical material can be extremely overwhelming. Even if you can manage the sheer volume of theoretical material on the subject, there is no knowing what would work in practice. This video focuses on the compilation of an interaction with my mentor on childhood trauma and its impact. Our interaction helped me gain perspective and understand how trauma can be approached better in practice. Where do I start? I think it helps if I use a case for discussion. This will help you understand the dynamics that come into play in practice. But before I share the case, I would like you to keep a few things in mind. Make a note that major traumatic events can change the way children perceive themselves and others and change the way they behave. Another thing that should be noted is that abuse, including sexual abuse, can be disabling and should not be treated as just an unfortunate experience. Knowing about childhood trauma will help you to understand and respond appropriately to a child. Let's take an example. Nakul is a 9-year-old boy who you interact with at an NGO where the Child Welfare Committee has placed him. Your interaction with Nakul makes you realize that he knows very specific details about sexual intercourse, something that is not expected of a 9-year-old. During a subsequent meeting with Nakul, you find out that he was very close with his uncle. You're talking with him now, and he is telling you about how he is good at keeping secrets, like the one that stayed between him and his uncle. While telling you about the secret, the boy's voice drops. He stops making eye contact and he appears to withdraw. What is happening? What do these signs indicate? Nakul is reliving his very frightening experience at the hands of a trusted member of the family and is likely feeling scared, helpless, and vulnerable. He is becoming distressed, and using a trauma-informed approach, we can try to interrupt his progressively worsening anxiety. For example, we can acknowledge his emotions, bring him back to the present emotionally, and offer him choice and control. We are aware of his distress and seek to address it. We might say, I can see this is really hard for you, Nakul. You've been through some very difficult and painful times that no one should have to experience. I appreciate you telling me about them. You have a lot of courage, Nakul. Pause. Would you like to take a break or maybe have a glass of water? What is this approach called? This strategy is referred to as the trauma-informed approach to interacting with children. The trauma-informed approach embodies several critical concepts. It takes into account the impact of trauma on a person and encourages us to make every effort to minimize any re-traumatization that may occur during our efforts to help. When using a trauma-informed approach, we avoid asking irrelevant questions about the trauma events, which may cause unnecessary anxiety and stress. And we avoid blaming or shaming a child for what happened to them. We are acutely aware of verbal and non-verbal cues that the child is becoming distressed while speaking with us and promptly take steps to soothe their anxiety. Let's say I'm a doctor, a counselor, or a police officer. I need to question Nakul about his experiences with abuse. Before beginning to ask sensitive questions about his traumatic past, I say, Nakul, we've been talking for a while about things you like to do and your favorite sports. Now, I'd like to ask you some questions about your life with your father, his relatives. The reason I need to ask you these questions is to find out more about what happened to see if there is something I can do to help you now and in the future. But you don't have to answer my questions if you feel uncomfortable, or you can answer some but not all of them. We can go as slowly or quickly as you like. Is it okay if I ask you some questions? The trauma-informed approach is victim-centered. That is, all actions and decisions regarding the traumatized child are done with the child's best interests in mind. These best interests must take priority over the needs of investigators to build a legal case, the needs of medical providers to follow a given protocol, or the desires of service providers to accommodate parental requests. The child comes first. In this way, I have maintained transparency about all that is happening. This reduces stress related to uncertainty. I've obtained truly informed consent and have demonstrated respect for the child's desires and feelings. I have given him a choice and a sense of control. This empowers him and further conveys respect.
What specific elements of trauma-informed care did you find striking? And what do you think, do you think the healing processes need to address? If I were to put this question to you, please do use the chat option to share with me what you feel. What specific elements of trauma-informed care did you find striking? I can see a lot of issues coming up from Dr. Agarwal about being circumspect, being child-centric. The child should not get, Anupama says, not be blamed. Kavita speaks about work on the relationship first. Sangeeta speaks about how to take the child into confidence, the whole issue of building relationships, building comfort, building respect, building safety. So you see, it all some of the very fundamentals of communication skills and of just talking to a client, a patient. This is not about some very abstract or some very complex healing process or some very complex dynamic therapeutic process. This is very, very simply how you put the child in question as the center of all thinking, and therefore give the child an idea of what healing actually entails. So these are the key elements, friends. How do you introduce yourself and your role? How do you validate difficult emotions and experiences? How do you exercise circumspection on your own responses? How do you embed all inquiry in the above techniques of interviewing, never coercing a child, asking open-ended questions, allowing for the narrative to emerge? Remember, I spoke about child trafficking and, in the ultimate healing process, this whole raid, rescue, repatriation, reintegration, rehabilitation, redressal paradigm. So you raid the sex work area, the child is rescued, repatriated to a temporary shelter, reintegrated with the family, if available, if locatable, and then there's rehabilitation and compensation and all of that. But it misses out on a very significant part of healing, and that I call as reclamation. Reclamation of personhood and reclamation of affirmative sexuality. Look at the whole drama that unfolds. Now, one may argue that do pediatricians actually deal with children who are rescued from trafficking? My response to that is as we go ahead in the expanding ambit of our work, particularly with the role that I Counsel of the Indian Academy of Pediatrics has to play, and I'm sure the Adolescent Health Academy will soon follow suit to really look at the element of adolescent safety, adolescent reproductive health, as well as social adolescent health, and the role that you'll have to play in all these processes. So look at the trauma that occurs even in this whole drama that unfolds during the raid rescue operation, and how crisis may occur at any of these stages when you have no control of the situation. But as pediatricians, some of the issues of injuries and diseases on the one hand, and then PTSD on the other hand, and then social support to begin the rehabilitation process. And the issue of is the family often the best place the child for to be in, particularly a child who's been trafficked with complicity of the family. And instead of believing in agar family hai, to, that's the best place for the child to be in, why don't we improve our childcare institutions? Shouldn't our focus be as much on improving the scale and scope of operations of childcare institutions, because they may be much safer than a child family who will re-traffic the child? And then the whole rehabilitation paradigm seguing into trust-building exercises of the survivor in the service provider, of the survivor in himself or herself, to the various redressal schemes. And these are things we should be aware of. The Ujjwala scheme to assist child trafficking victims. It was started in 2007. And it can be accessed through the Women and Child Department, Social Welfare Department of state governments. Then there is a national compensation scheme for survivors of sexual assault by the National Legal Services Authority. It can be accessed through the district legal services authorities. But coming to reclamation, the focus on healing and recovery, a lot of these kids have very difficult feelings. They're sort of trying to make sense of the abuse experience and reclaiming their identity and selfhood, trying to understand about sex and sexuality, personal safety. Can I reclaim, do I have the right in a future loving consensual relationship to engage in physical and sexual intimacy of pleasurable connotations? How do I address other high-risk behaviors? So this is otherwise this.
Hi, I am a 27-year-old woman based out of Delhi NCR. I was 7 years old when it first happened and 8 when it happened for the second time with a second family member. The first time when it happened, it was my paternal grandfather. My parents had gone out for the evening, leaving me alone with him. And he used that as an opportunity to abuse me. The second time around, it was my mom's cousin brother. And while playing one afternoon, he must have been about 19, 20 at that point. So it was just me and him playing some game, I don't remember. But what I do remember is, what he did to me. And, it still haunts me today. When it happened for the first time, I told my parents what had happened. I was very confused. I didn't know what had happened to me. All I knew was that I was in a lot of pain. My parents didn't know how to react. And I actually enacted everything out to my mother. While my father didn't really say much, actually he didn't say anything at all. The very next evening when my parents had to go out again, and he was okay with leaving me alone with him again, I was really hurt. And even today, it still hurts me to know that my father did not stand up for me, like my very own biological father. He couldn't take a stand for me because it was his father in question. My mother was the one who raised her voice against it. And in exchange, my grandparents just asked us to leave the house. The second time around when it happened, I told my mom and maternal grandparents the very instant. And what they did was throw him out of the house. They asked him to leave. They asked him to, move to Punjab where my grandparents own property. I'm actually going to say that this incident haunts me more often than not because I developed a nightmare problem since then, wherein I get repeated nightmares of abuse happening to me again and again and again, and me being completely helpless and not being able to do anything about it. And I have woken up almost every night sweating, screaming, crying, asking for help. So yes, the incident affects me even today. It affects how I see the world. It affects how I think about the opposite gender in general. And I do confide into my mother about it. I keep her in the loop. So whether it's a nightmare or whether it's a bad memory flashback, I always do talk to her about it because she's been my biggest support through all of this and she's helped me move on from there. I haven't ever considered approaching the legal system really because very frankly, considering how the legal system in India works, it would just mean, going through a lot of rounds of the court and, having to relive everything that had happened. And I don't think I will ever be prepared to do that to myself.
How interesting that the very point that was asked as a question about night terrors and nightmares comes back to not that I had made a prediction that the question would be asked, but Carl Gustav Jung would have called this synchronicity. कि कैसे एक सत्र में, our collective thoughts and concerns sort of come together as a coherent voice. And therefore, in your chamber practice, whether it is solo practice or whether it's in a nursing home setup or whether it's a teaching hospital, as the case may be, if you bring this approach of really eliciting narratives for your adolescent to feel this is the doctor I want to meet because I'm able to tell my story, which is heard with attention, sensitivity, respect, helpfulness, strategy, so that I feel a sense of restoration of my agency. Remember the four traumagenic dynamics: traumatic sexualization, betrayal, stigmatization, and powerlessness. And when you restore stigma, the whole thing of guilt and shame, and when you change that through the identity exercises, when you get them to speak about relationships and the whole issue of trust, mistrust, when you allow them to determine their choices, you restore to them what their sense of powerlessness actually involves. So this is what I wanted to share with you in this part. The final part of the session today will be the legal sort of literacy, so to speak. It's going to be a continuing education sort of thing on various provisions and laws of POCSO. But before we do that, again, we'll take about 10-15 minutes to really address issues that anyone would like to put on chat. I already see that many people have posted comments and such as Asha, this is in response to I see that Kavita and Kiran ma'am and then Sridevi have posted comments in reference to the earlier video that we had seen. But to Neha's story and the whole issue of nightmares and the kind of restoration that you can do based on the principles that I have spoken to you about, I would be happy to receive your comments and questions, and I'll request Kavita to curate them for the next 10-15 minutes, and then we'll do the last session on the law. So please go ahead and post your questions.
Audience, all the questions, please welcome. You can post your questions here. Dr. Jagdish sir is writing reclamation would be easier soon after the abuse.
The timing, Jagdish and friends, of the various sequences of things that occur depends a lot on whether the concerns of the adolescent is in an acute agitation, turmoil state or beyond that. Let me explain what I mean. When an adolescent comes to you in the aftermath of an immediate abuse, something that has happened today, yesterday, a week ago, not 6 months ago or 1 year ago, and is still contending with the confusion and the trauma of that, and there's a lot of agitation, that's not the time to do memory work. That's the time to do containment techniques, relaxation, journaling, routine. Memory work comes later, and the reclamation work comes later because there are many immediate issues to deal with. So that sequencing is exceedingly important. The second thing that I want to say in this connection is we've had instances where a child has established abuse, FIR has been lodged, the child has significant mental health issues and is admitted to our ward, and the investigative officer comes to collect the 161 statement. And this has happened several times, so I'd like to share what plays out there. The investigative officer says, Doctor Saab, आप हमें 161 स्टेटमेंट दिलवा दीजिए, आपका काउंसलिंग चलता रहेगा. The hands going like that. आपका काउंसलिंग चलता रहेगा. Get us the 161 statement, your counseling can go on. To say with due apologies, sir, the main reason the child is admitted here is number one, for rest and relaxation. Number two, for the child to put forth her predicament and problems for us to respond. Number three, to look at mental health, psychiatric trauma symptoms to heal. Number four, to look at legal forensic processes. Not necessarily in that order. Of course, we will tell the child there are legal processes, kanuni karwaiyan hai, but don't worry about it. There is no hurry. We can do it a little later. There's no need to be. So you're already hinting to the child, but not sort of pressurizing the child ki, you must give us the evidence and the information right now. If you don't tell us, then how can the case be processed? You cannot be harassing and haranguing a child. So in that sequence of events, the beginnings or the hint, the context, the introduction of the reclamation process can certainly occur at the outset. To say that you have every right for your aspirations, every right for your dreams. We'll try to ensure that this does not come in the way of what you wish to be. And also, if you recognize the inner voice that leads to that reclamation, if I am in love 6 years from now, should I tell my my boyfriend or my fiance that this happened to me. Now, many girls who've been trafficked and rescued, good family, they are repatriated to the family. Say, when people in my town or village ask me what happened, what do I tell them? And we always tell them, listen, don't feel pressurized that you have to tell a lie. And we actually work on a script with them. That's part of the empowerment and the reclamation. There is no need to tell them that in the 8 months before I was rescued, I have seen 800 men with their pants down. That's not what you need to tell them. What you need to say is, look, because of family financial situations, there was a discussion to see if I could go to work to supplement the family income. I was hopeful that it would work out, things would be congenial. Unfortunately, the circumstances was not very good. I don't think I could have lasted there. I wanted to get away. It wasn't very easy. It took a lot of time. You know how uncooperative and bad people can be sometimes. But finally, due to some assistance, I have managed to get away and I'm here. Thank you very much for your concern. I'm really you told the truth. So there is no obligation on you to go into all the gory details of. So that's how the reclamation process actually kind of takes place. So let me be a little more pithy and short in my responses. I see that there are at least 10 or 12 more things put on chat. Some of them may be comments. Go ahead, Kavita.
Dr. Shobha is asking, can you give some examples of response statements from the doctor, listener, therapist?
It's very tempting for me to, if there was a script available of what really is reassuring. But let me respond in two ways. The child asks the therapist, Doctor, do you think I'm bad? Okay? Kavita मुझसे पूछो, Doctor, do you think I'm bad? पूछो मुझसे.
Yes. Doctor, do you think I'm bad?
I don't think so. Okay? Child says, why did you hesitate for 3 seconds? What was that? I don't think so. क्यों hesitate किया आपने? Whereas if your response, फिर से पूछो.
Doctor, do you think I am bad?
Of course not, child. But no, I don't think so. But it would be important to understand where this question is coming from. Perhaps you have some doubts in your mind. Perhaps someone said something. I'd be happy to discuss it with you so that things are clarified. देखिए response में क्या फर्क है?
It's true.
तो उसी तरीके से we often, when we teach counseling, we have something known as the helpful responses. It's for trainee counselors. And it's a VNet kind. So this is not about child abuse or adolescence. A woman says, my husband came home last night. He was very drunk. He hit me and broke the television set, and I just didn't know what to do. If you wanted to be helpful, what would you say next? We do this as a written exercise. So somebody writes, I'll try to be reassuring. And my response to that as a teacher is, I'm not asking you what your intention is. Your intention to be reassuring is important and significant. What will you say? तो वो लोग लिखते हैं, did you do anything to provoke him? अबे, how is this helpful? No, you must not tolerate this. You must go away to your mother's place. Also not very helpful. But to say, that must have been difficult. I wonder how it ended. How are you feeling now? Are things all right? And can we discuss a bit about your support systems? So you see, how do you generate helpful responses? Of course, we have a whole list in Sambad's materials about potential first-level responses. But what if the question is different? So I don't want to give you a script for you to say later, अरे सवाल इन्होंने बदल दिया संवाद वालों ने तो इसका जवाब ही नहीं लिखा मैनुअल में. So yeah.
So the next, Dr. Anupama is asking, there have been incidents where the victim takes revenge against the abuser after a few years. So your remarks on this?
We are going into the realm of sociological analysis and social theory. Is revenge legitimate? It depends on how um, enraged and resentful and outraged you are about something that you believe that retaliation or revenge or action is necessary. It's also an ideological, an eye for an eye will make the whole world blind. Uh, an eye for an eye, a tooth for a tooth, a hand for a hand, and a foot for a foot sort of. A lot of the principles that we follow, Kavita, in this regard, come from peace studies and conflict resolution studies, also from the principles of reconciliation psychology. Now, please understand that when we speak about restorative practices, it's very difficult. Restorative practice is about perpetrators acknowledging harm done more than victims forgiving the perpetrator, because I don't think you can harass a child to forgive the perpetrator. And I've had a lot of discussion this, particularly with religious groups who do pastoral counseling, who believe that forgiveness is central to healing. And my position on this is very clear. It is not. And you should not harass a child to forgive. It's a different matter if the child wishes to and believes that that's important for me, but you cannot harass a child to do that. There are other principles of healing that are far more evocative and far more powerful than the whole issue. So if I'm dealing with a client whose position is one of revenge, I would have all these discussions. So I'd go to the future to say, I'm not saying yes or no, I'm not saying right or wrong. I'm not saying, are you out of your mind? I'm not saying all of that. I'm just saying, let's envisage how far this will go. Supposing you were to do this, what are the next steps that would happen? And then what would your response be to that? And what kind of, and is that the kind of investment that you wish to make? It's your choice. And so that's how that's what counsel means, and that's what responses mean, that you always take a position which is one down, never to say that that's absurd or don't be crazy. That's a crazy thing to do. You'll be endangering yourself, jeopardizing stuff, you know. You'll exhaust your resources. You have everything to deal with, because it's already 3:15, and I have one more section. We can, of course, always skip the legal section and just go ahead with all these questions and convert it into just that, and then end at 4 and maybe organize a legal session at some other time. Because actually, if you ask me, the legal session doesn't really fit into the spirit of what we have done today, and indeed the spirit of this entire series as I have understood it. So I think we can have a special webinar later to deal on the legal aspects, and I feel it'll be useful to stick to this Q&A, and then we can have some closing comments from MKC, from Preeti, from Kiran, from Arun Dapke, Jagdish, all the people who have been in the field for decades, and bring with them the wisdom of experience. So that'll be very useful to close the session. So let's continue with this Q&A.
So, sir, Dr. Soumya is asking, sir, I'm a social worker, counselor in Pediatric Hospital, Srinagar, and I have adolescent patient. His neighbor has abused her. She sees him every day, and it's really difficult for her to forget this traumatic event.
Sorry.
One girl is abused by her neighbor.
Neighbor.
Now every day she has to see that. In the neighbor.
And the matter has not been brought to the notice. The reporting has not been done. Processes have not started. The thing is that if any kind of recompense or sense of justice, um, the problem is that the world of children is characterized by deep and concerning levels of epistemic injustice. Everything is geared, court systems, they're not geared towards supporting the child at all. They're absurdly inimical and antithetical to child well-being. So, Kavita, I must tell you another story. A neighbor ki hi story hai. This was a young adult I had worked with many, many years ago. Expat India, living in one of the Middle East countries, high-rise buildings, two high-rise buildings connected by a bridge and then a lift at either end. Neighbor, and the neighbor often would corner her in the lift and then grope her and feel her up and stuff like that. Now she was intelligent and very savvy, enlightened. So it was not that she was traumatized by the actual act of groping, but she said for 3 years in their apartment complex, all I can remember is constantly ducking and hiding. How can I avoid this guy was her preoccupation from morning till evening. So watching to see has he left, getting someone else to call his home to see whether he's there or not, taking the lift to a different floor, going to the other building, getting off at some other floor. And she said it got crazy after a while. Now the point is, uh, how do you desensitize yourself if you have not complained, you have not reported, processes of legal recompense have not started, or legal healing has not started, and she's sort of disclosed this to the counselor, but not to or the family knows and they are not doing anything about it. So there are all these social interventions which are necessary to feel empowered. That's people are taking action, and I'm not alone in this. That's one part. The other part is the actual distress that comes in the viewing of him. Now that can happen even if you don't see him, but someone speaks about him, or even seeing his photograph of someone mentioning his name, or seeing some stranger who resembles him, or something. And these are all trigger points. So if you look at John Briere's self-trauma model, these are called the difference between implicit, explicit, and autobiographical memories. And that's where we use trauma-informed CBT to really do away with the trigger that happens whenever she sees him. Now, that's a specialized form of intervention, trauma-informed CBT. So, if you read John Briere, self-trauma model, there is a whole model of how you deal with these kind of implicit, explicit, and autobiographical memories. Next, Kavita.
So there are no more questions. So if I can, throughout the entire session as a pediatrician, like the practically सर ये होता है कि जो socially pressures रहते हैं, so people don't complain, or even घर के अंदर होते हैं, they don't even disclose the things. So as a pediatrician, only what I suppose the role that we have to train the victim to empower the victim to face all these things and come out of this. Because they have to see the जो उनका साथ जो किया उसको तो उनको everyday देखना है, if it is in the family, in the neighbor. So what we pediatricians are supposed to do with them?
What you pediatricians are supposed to do with the neighbor?
To the victim. मतलब मुझे ये लगता है कि this is what कि if they are not ready to file the complaints, they are not ready to, like अगर घर के अंदर होता है, जैसे आपका वो केस था जिसमें grandfather was doing, तो यहाँ पर मदर ने उसको सपोर्ट किया, बट 90% केसेस इवन द मदर वोंट सपोर्ट. They don't even disclose this or discuss with anyone. So the victim has to live with all these situations. So the empowering these victims to stay with the situations and come out of all this, facing every day the same person. So the tips on all these aspects. That is actually practical story. जो practical cases आते हैं, this is the same story. मेरे पास 3-4 बच्चे ऐसे हैं जिनके साथ उनके घर में ही कुछ ना कुछ हो रहा है, लेकिन उन relationships को वो पॉइंट आउट कर ही नहीं सकते, ना ही वहां से भाग सकते हो. They have to live with them.
One of my favorite phrases these days is frame of reference. कोई भी पेशेंट हो, कोई भी समस्या हो, कोई भी संदर्भ हो, always apply a frame of reference. Let me explain what this means in the specific context of the जिस प्रकरण को आपने अभी व्यक्त किया है, what you have said just now. As part of the frame of reference, one frame is the legal frame. हम रिपोर्ट नहीं करना चाहते हैं, we are afraid, we don't know what will happen. Please refer to what Preeti has already posted on our 7-step mandatory reporting process. After you do that, whether they still report or not, at least they know that there is a process, there is no hurry, no one is hurrying us. We are entitled to report, we have the right to report. There is a system of justice, however limited one may believe it is, that exists. कम से कम इतना पता चल गया, as opposed to कोई फायदा नहीं है, nothing can be done. So that's one frame of reference. The second frame of reference is how do you keep intact your identity and aspects of your life and not allow this person or the visualizing or viewing of him on a daily basis to basically affect what your aspirations are. Nobody can stop you from aspiring. आपके सपने जो है, आपकी अपेक्षा जो है, कोई रोक नहीं सकता. वो आपका जन्म सिद्ध अधिकार है. Let's build on that. और वो आप प्राइवेटली करते हैं. आप गाना सुन रहे हैं, you're listening to music, you're drawing, you're doing online work, you're talking to friends on WhatsApp. So you're keeping your life intact. Your life is not overwhelmed and preoccupied with the experience of seeing this person every day. ये second frame हो गया. The third frame of reference is without getting into anxious avoidance and changing your route and so on and so forth, and changing the time. That is allowing yourself to become a prisoner or entrapped. How can you minimize either this contact or minimize the impact of this contact? And that's where trauma-focused CBT comes in. Because what is this? The seeing of this man is a trigger. It triggers the trauma memories. So there is a way to handle that. This is the third frame of reference. The fourth frame of reference is to look at family dynamics, to look at how much they know. Do they know? How much they know? What do they know? What is their orientation? Are they supportive of the child? If not, can we enhance that support? So this is what I call as a frame of reference. So for any individual, any problem, or any challenge, if you apply the frame of reference paradigm, you will always present to your client something which convinces the client that I have options. And I have options that have been presented to me in a way that are reassuring and comfortable. I don't feel pressured, hurried into anything. I can do this in my own time, at my own comfort levels. This is good. I feel good about this. Things haven't healed completely. I still have nightmares once in a while. I still feel a little agitated. I still feel angry sometimes when the thought comes, but things are better. So healing and recovery is not about a magical and a total transformation. It is a process, and sometimes we always carry with us the scars of our injury and trauma to our dying day. But that doesn't, neither the scar nor the trauma describe or define who we are. And I think that principle is exceedingly central and critical to any healing process. ये एहसास दिलाना कि आपकी शख्सियत जो है, आपका व्यक्तित्व आपके सदमे से परिभाषित नहीं होता है। सदमा जो हुआ मानते हैं, महत्व देते हैं, होना नहीं चाहिए था, दुखदाई था, लेकिन आपको परिभाषित नहीं करता है और करना भी नहीं चाहिए।
Right. Very true, sir. Sir, Dr. Shubhata is asking what should we advise the parents and caregivers to reduce the distress during the actual flashbacks of traumatic experience?
Sorry, during the actual?
During the actual flashbacks of traumatic experience, what should we advise to the parents to reduce the stress? How to de-stress at that moment? If the child is in...
आपको याद है MKC सर सुबह अपने संबोधन में when he was saying कि I was in Punjab for 10 years and मेरे में पंजाबियत आ गई, मैं तो जादू की झप्पी देने लगा, and when I came back to Dakshin Bharat, people are saying, what are you doing? All this hugging and touching, this is not part of our culture. Where, see the जिसने भी मतलब मुन्ना भाई सीरीज देखा है और जादू की झप्पी जो है the reassurance essentially when someone is in a state of agitation, देखिए cranky बच्चा जो है, as pediatricians you know, how do you soothe a child in discomfort? Remember what I said about perinatal psychiatry? A mother who's depressed, a mother who's psychotic, unable to bond with the child, unable to soothe the child. And why a child's emotional regulation system, if a child remains unsoothed when the child cries because of pain, hunger, discomfort, or separation anxiety, if you do not soothe the child, that portion of the brain that regulates emotion does not get developed, amygdala. Or chronic trauma, this has been seen. fMRI studies in chronic trauma have demonstrated that portions of the amygdala that are related to emotional regulation are affected. So, with the agreement of the adolescent in question, we know you have this, we know it's disturbing. These are symptoms of what you endured. They are not abnormal. What happened was abnormal. These are normal responses to, so you don't pathologize PTSD symptoms. And you say, with your permission, when you have these flashbacks, would it be all right for mama, to hold you, because, how close you're to mama and perhaps, or would it be all right for Appaji to sit, next to you and hold your hands and how you love singing and he loves singing, to provide you an alternative experience that takes away from the flashback. This is not to belittle or trivialize the flashback or its how disturbing it is. It is just to provide a moment of respite. क्षण भर के लिए अगर आराम मिल जाए तो वो the arousal comes down. So these are the kind of approaches that one really takes to deal. So these are all containment techniques. Go back to what I said about containment techniques.
So this I think you have already answered. Rather than teaching victim to be careful, should parents not be convinced to take action against such acts? So
No.
definitely we have to tell them what the options they have. You have already answered.
Yeah. I mean, Kavita, सत्य तो ये है that no matter how traffic conscious and law abiding you are, you're always subject to someone else's error of judgment.
That's true.
तो कितनी भी आप सावधानी बरतते हैं, of course we are careful, yeah. We drive carefully, we look at each side of the road, to judge, but we are always subject to someone else's error of judgment. कोई पी के चला रहा है, कोई रैशली चला रहा है, who knows, yeah. But we don't start not living life on the basis of fear. If fear becomes the default mode, as Sigmund Freud said, the two basic instincts of Eros and Thanatos, कि और आपको याद होगा कि जब पांडवों से पूछा गया था कि आपको सबसे आश्चर्य वाली बात क्या लगती है दुनिया में, यू नो व्हाट युधिष्ठिर's आंसर वाज? He said, everybody knows you have to die. But I find it most surprising that people have a difficulty in accepting it. That was his answer to this question.
That's
Uh,
right.
so what I'm saying is, sure, one must be careful. Of course, we are not stupid that we'll be doing risk taking and all of that. So everybody tries to be sensible, lead your life in a sensible way, in a healthy way, in a careful way. Once in a while मस्ती करने का मूड करता है, and that's all right. And sometimes मस्ती ज्यादा हो जाती है, वो पता नहीं लगता, या मस्ती आप नहीं कर रहे हैं, आपके साथी कर रहे हैं। आपका तो इरादा एक दो पैक पीने का ही था, आपको मालूम नहीं था कि सालों ने गोली डाल दी उसमें। क्या ये सब होता है दुनिया में? तो
So,
so, but again, frame of reference. Sure, be careful. Sure, we'll always be available for you no matter what. There are resources and recourse available to you. There are things that you can look forward to in future, in spite of something that may happen, uh, despite the fact that you were careful. Frame of reference, so that they don't uh, make what happened that much more awful. वो फिर हाय तौबा में बदलता नहीं है वो।
so now there are no further chats. So if we should invite people to make their comments or what?
Yes, please, बड़ा अच्छा रहेगा।
जी जी सर, सबसे पहले तो मैं आपको कॉन्ग्रेचुलेट इसलिए करूंगी कि more than 75% attendance till now you have retained. So this is your magic, sir. So may I request Dr. MKC sir to please give your
अच्छा नहीं कविता, वैसे हाउ मेनी?
सर 137 था।
No, I mean overall when you started, how many had registered?
सर स्टार्टिंग फर्स्ट एपिसोड में 300 प्लस था, उसके बाद से 150 के अराउंड रहता था।
No, what I'm saying is when you started, you didn't have people who had registered for the entire webinar series.
So people had registered. We had right from the beginning more than 600 registration in the beginning also. And now
So
we
that's
have
what I
around
want to know.
1,000. Yeah, more than 600 registration.
That's what, no. I'm asking for a particular reason, because I basically, what's the word? I'm not finding the right word. I log all the work that I do. So when I log what I've done for the Adolescent Health Academy, I would be logging 600 and not 134. That's my
so
point.
then you log 1,000, sir. We have more than 1,000 in our group.
because
and all those 1,025 members, and all of them are asking for recording.
Yeah, that's
so
what I
they
wanted.
all know. So they all know that they will get the recording. So that's why. But still, we have more than 100 gathering. That is a good thing, sir. So because I joined so many sessions, I never see so much attendance in any sessions. So that's our success actually. And till the end also, we have retained so much of attendance. MKC sir, may we have your comments now?
Yeah. Okay. Needless to say that we have enjoyed this session fantastic. No problem. We have enjoyed it so beautifully. No problem. The first point I would like to say is that he has every question was asking for prescription. How to do this, how to get rid of this. And what he has given is an approach. Okay, that is a big thing that I found in this. If you have this problem, what will you do? No, instead of that, give an approach so that whatever problem comes, you have a common approach available. That is a very important point. That's very beautifully, I think he has emphasized it very well. Number two would be, from the day this good touch, bad touch came, I never believed in that. And I'm happy that he is validating that. Rather than sometimes children understand if you say, which I wrote in my book also, nobody has a right to touch your private parts, except maybe your mother for bathing or your doctor for some examination in the presence of the mother. So that is something which I have been popularizing. I never liked this good touch, bad touch business. Came from West, people did that. Number 3 is, I believe this should be a beginning of empowerment of pediatricians for counseling. Okay. That probably that the next president should take it up. That it should be a beginning of a larger process of counseling, which individuals cannot do, but group can manage. We may even think of certifying them under the academy, for counseling, which means different kind of people. Shekhar gives more of, he doesn't give a talk, he gives a discourse. He evolved from one to other like that. That is one approach. There are people who need, 1, 2, 3, 4 points, prescriptive. So that approach is sometimes okay. Some people only talk on experience, just experience. I had this case, this is the way I managed. Maybe this is the better way, or maybe there are better other ways. So if you bring in a whole lot of things, probably we can make adolescent counseling as a real, and an academy can actually certify that. That may be a great approach. That's why these are 3 comments I would like to say. Shekhar, your comments on that.
Thank you, sir. Thanks a lot. Sir, Shekhar, sir, you want to say?
No. The MKC is raising a very important issue, which as an academy, you might do well to consider. His point is about pedagogy.
Yeah.
And about teaching methodologies. So there are different kinds of teaching methodologies, and what Samvad has been doing over a period of time is we have evolved methodologies which are exceedingly experiential. They're not didactic, they're not information or content loaded, but they are geared towards field practice and actually what happens on a one-on-one situation when you're meeting with a client or with a family. But those kind of pedagogies lend themselves well when also let's understand, friends, there is a difference between orientation, sensitization, skill building, and capacity building. Capacity building cannot occur in webinars. It calls for a much longer period of engagement where we actually do practice as well. One of the reasons why I requested Kavita for a longer session was in the hope that we could actually do practice sessions so that there is an element, it is still not capacity building, but a certain element of skill building would come in. So I think going ahead, if the academy were to spend a lot of time in the internal discussions on these kind of pedagogies, remember the intent, content, methodology, process, paradigm, and the kind of pedagogies. So the point that MKC made, one is, overarching approach related. The second is point wise. In this condition, do this. This is your SOP. The other is you do a case-based discussion. So if you can curate programs that are a mixture of these 3 paradigms, but do them over an extended period of time in 1 hour is difficult. So what could happen, for example, in a 3-hour session is that you have a 45-minute session which is discursive in nature. It presents an approach. You have another 45 minutes which is a point-wise thing on the specific condition and your SOPs and protocols. And then you have 90 minutes on cases and how you can approach it. So see how beautifully it can sort of blend in together. So that's a point that we could draw on to basically strengthen the pedagogical practices of the academy.
Right. Thank you, sir. Thanks, sir. May I request Dr. Jagdish to please comment?
Thank you. Thank you very much, Dr. Kavita, for inviting me to speak. It's one of the few sessions that I've sat right through without even blinking. And I think thanks to Dr. MKC Nair first, who introduced this new concept of family-oriented therapy and family therapy too. The second sessions which are taken by Dr. Shekhar, phenomenal amount of material, sir. Thank you so much. The only problem is that we now need to digest this material because there is so much of it that I think it will take a long, long time for us to really get into the depth of all that you have spoken today. Because I think every sentence of yours had so much of background information going into it that it is very easy for you to take it through. I mean, take it through us, and we all understood a lot of it. But I'm sure that I've recorded all your lectures, and I'm going to go back and keep listening to them again and again so that I understand more and more about this. And I was also very happy that a major part of ethics was brought into this topic, especially the best interest standard was brought in, how the child is at the center, what is basically looking at the ethical principles there. And I also liked very much how you had a systems-based approach for almost everything that you said, that there are going to be systems. You need to look at the stakeholders. You need to look at outcomes. You need to look at what are the information sources you have. So many other things that are brought in. So thank you very much, sir. I hope that we also get, in addition to all that you have said, we get two things out of the academy. One is probably a 2-month or a 3-month slow-paced teaching program, which can be online, because that will basically take you through the nuances of what you have spoken. And second, maybe an internship for some of us at Samad for a short period, maybe a week or so, to look at actually what goes on. I'm sure Preeti has been very lucky to get that, opportunity of being in Samad with you. But I think a lot more of us need to be also there.
Very right, sir. Very right.
You,
Thank you, sir.
Thank you.
May I request Dr. Kiran, ma'am? Dr. Kiran, you can unmute yourself. Ma'am, you can unmute yourself.
Okay, yeah. Yeah. Hi, Kavita. Starting with Dr. MKC Nair. I just heard him 2 days ago again. It was just like I just had my cataract surgery, and it was just I was not able to tolerate the light, so I just closed my eyes and I was listening to him. It's just like meditating and focusing. I mean, it was a wonder. It's just like Sadhguru of Indian Academy of Pediatrics. I don't know from where his knowledge comes, and he can speak word by word so accurately. Nothing is used, and long time to remember. Dr. Shekhar, a long time friend, dear friend, and he is really amazing what really he speaks. And it's so much. I mean, I can sit, I don't know, from days together listening to him. It's really, thank you so much, Shekhar ji. It's, I just wanted to know, when are you meeting the new minister? I was also thinking to meet her.
27 का appointment मांगा मैंने.
27. Okay. Actually, 27. I was just thinking if I can go with you. 27th, probably I'll be in Nasik. This adolescent conference.
Yeah.
But can I speak to you? What is the best time to speak to you? I just wanted to discuss with you regarding this FOXO review is there.
Yes.
I hope you know about it.
Yes, I do.
So I'm just doing some interaction with the NIPSID regarding it, what to be discussed and all that. what is the best time to speak to you?
Kiranji, any time is a good time. I sleep late, I get up early, and I don't sleep in between.
Okay, thank you so much. Thank you so much.
Thank you, ma'am.
Thanks a
Thanks a
lot,
lot.
really. I also would like to attend your Samvad courses. I didn't get really, time to earlier, but I'll definitely do that.
Surely, ma'am.
And
Thank
Dr.
you, ma'am.
Jagdish, he is also amazing. His inputs are also, really very, very good. Thank you, Dr. Jagdish.
Thank you, ma'am. Thanks a lot. May I request Dr. A.T.
Thank you,
Dapke, sir?
Kavita. And to you
ma'am.
also,
Thank you.
Kavita. The way
Thank you, ma'am.
did it. Thank you so
ma'am.
much.
Thank you. Thanks a lot.
I'm in a conference, just to inform you, I'm in a conference in Delhi. This is IAP Delhi's conference of North Zone. And I listened to the full, Dr. MKC Nair and Dr. Shekhar in the washroom, because here it was so noisy here, and my battery was going down. So I just put it, I plugged in the washroom, and I listened the whole thing there.
So that's the magic of Shekhar sir and MKC sir.
Yeah, the magic of both Dr.
Yeah,
MKC Nair
that's
and
nice.
Dr. Shekhar.
That's
Both.
nice.
Thank you so much.
May I request Dr. A.T. Dapke, sir?
May I come in, Doctor, now?
Thank you so much. Hima is here. Hima is here.
Yeah, I know. I know. I'll call one by one.
Thank you, ma'am.
Sir, I know.
And yeah, for all the persons, I would like and the and group. Thank you. It was a wonderful session. Very useful.
May I request Dr. A.T. Dapke, sir, to please share your comments?
Very, very learned speakers, Dr. Nair, Seshadri ji, Preeti, and all others. For me, it's a very difficult job to speak. My worries are little different. Our country is fastly progressing as far as population is concerned. There is marked increase in not in severity of poverty, but number of poverties, people, families, and residential problems, diet, all problems are beyond, I think, should say, our control. And this leads to abnormal behavior of mostly father and sometimes mother also. And third situation, which is more common in our big cities like Bangalore, Bombay, Chennai, Delhi, parents have to go to work just to keep their tummies full of their family. They start early morning and they come back late evening or night. Both mother and father have to work so that they can survive. So in this situation, the behavior and psychiatric problems in children are quite plenty. Probably we are not in a position to complete evaluation. If we evaluate 100%, the things will be very, very depressing. And if the parents go for help or the patient goes for help to the police, to the judiciary, their response is also very, very abnormal. Sometimes they are further exploited. In this situation, I think our job is very, very important. And for us, I think the counseling should start from before marriage. And parents must know what are their minimum requirements as far as children is concerned, child rearing is concerned. And if they hand over their children to uncle or grandparents, probably the rearing is 50 years old and then there are conflicts. So I think we have to have solutions for these also so that our problems of adolescent are little under control. Of course, the environment is also not very happy. Teachers are sometimes abnormal. And I think all these things we have to manage parallelly so that our society is more comfortable. And again, I express my gratitude to Kavita Madam, to all the senior learners for they have taught us. And I'm sure we are all be thankful to all of them all whole life. Thank you very much.
Sir, thanks a lot for your blessings, sir. May I request Dr. A.P. Sawant, sir, to say a few words? Sawant, sir,
Yes, yes, Kavita. Actually, I am away from my original place. So I should say that this is the excellent session. I heard the complete session of Dr. MKC, sir. He has definitely started a new thing, and then I learned a lot of family as well as family therapy. It's a very good session, and Dr. Seshadri also taught so many things, and we learned so many things in a day. So it is very difficult to recapitulate most of the things. But definitely we'll ask him again to give his knowledge and wisdom to our academy. And congratulations to your team, Kavita and Dr. Preeti and Dr. MKC, sir, for organizing such sessions. Congratulations.
Thank you, sir. Thanks a lot, sir. Thank you. Thank you. Dr. Amar Singh Thakur, sir.
Yeah, good evening, everyone. And this was such a wonderful session today, not only today, but from the 22nd of the June, when we started this webinar, and we could cover many topics related to the adolescent health, and so many stalwarts of the adolescent health and the IAP, they all could come in this platform, and we were able to hear them, we were able to interact with them, discuss with them. So it was a very fantastic webinar series. As far as the starting of this webinar was from Dr. MKC Nair and Madam Preeti Galgali Madam, and those were the important topics that was covered in the adolescent counseling and effective communication, and that set the agenda, and that was the kind of the discussion that attracted so many pediatricians to come and to attend this webinar series, and we were very fortunate to become a part of this webinar series, and we could all interact with each other. Secondly, regarding the today's topic, again, we learned so many things from Dr. MKC Nair, like adolescent counseling, then marriage counseling, couple counseling, and now today it was a family counseling. So such a important and the core things that sir put forward for all of us. Not only it gave us a perspective for the patient, but it was for your own evolution. Rather, I would say your own understanding that how you can interact in your own family with your own situations, and we could understand in this process of many things that truly affected us also in our own behavior and thinking and emotions. So all these things we can understand and we can modify ourselves also. And similarly with this, we could help our patients, adolescents and children. And Dr. Shekhar Seshadri said, I was just listening him all throughout the day. Like he is a uninterrupted speaker, and as per said that there are prescriptive persons who will like, and the sir is something different. He will be like coming from one subject to other subjects, so endless. endless thing that he had, and not many knowledges that he is having, and he is sharing it with all of us. So it was fantastic, sir. And really, it was for me, it was a fortunate occasion to meet you, to see you, and MKC sir also, and all the stalwarts also through this webinar series. And yes, of course, the one point that we would rather like to contemplate how we are going to implement all these learnings in practice. So maybe it may take time, as Jagdish Sirappa sir said, that it will take time to absorb the things and to implement it. So yes, but since we know that when you work for an adolescent, then you go to the school, because the adolescent, they do not usually come to the doctors unless age-old like learning, teaching, or knowing that you visit a doctor when there is some physical problem, not for a mental problem or not for a developmental problem. So you have to make aware, and we need to make the aware the teachers, the gatekeepers, the parents, and to the adolescents themselves also, that what are the things that is important, and how we can help them. So that is a very nice thing, sir. And we could have not many things. हमारा लाइफ में एक नया पर्सपेक्टिव भी आ गया है, and it was very fantastic for the Chhattisgarh Academy of Adolescent here. And Kavita madam, so I'm like there is no word to say कि आपने कैसे मैनेज किया. आप जो है जस्ट मेरे बाद में प्रेसिडेंट बने हो, आई वाज प्रेसिडेंट AHA, और एंड देन आपने इतने अच्छे से हैंडल किया और इतना बड़ा प्रोजेक्ट लेकर आए और सारे लोगों को जोड़ के यू डिड अ वंडरफुल जॉब. सो थैंक
सर
यू
आपने
वेरी.
इतने प्यार से जिम्मेदारी दी थी तो निभाना तो था ना सर.
बहुत बढ़िया. मतलब it was more than expected, very very more than expected for all of us. So all the CGAHA members, we liked it. We never expected it, but it came like a surprise. प्रीति मैडम ने हेल्प किया, MKC नायर सर ने एक एक चीजों को एक एक दिन उन्होंने जो है देखा. प्रीति मैडम ने इतना सारा चीजों को किया. हर मीटिंग के पहले उन्होंने जो है एक ब्रीफ देते थे, जो कैप recap. So these were like things unprecedented. I would say this was unprecedented. Congratulations to you. And
thank you sir, thanks a lot, thank you.
Stalwart sir, जो हमारे साथ आए. Thank you very much.
Thank you sir, thank you.
Thank you very much.
Thank you sir. May I request Dr. Preeti madam, the light of this program, to say a few words.
Thank you so much, Kavita, for your kind words. But I would first request Dr. Jaipal. He's waiting for a long time to speak. And then Radha Rani to speak. And then I would speak. So please go ahead, Dr. Jaipal.
Thank you, Dr. Preeti, for bringing me in. I don't have the words of acclaim and appreciation. That's definitely going to be there. But I have many more suggestions. I'm advisor to WHO for School Health Program and contributing a lot over there. I've been director of AIDS Control Society, and recently, on this Sunday also, I'm speaking somewhere in a big panchayat which is happening on school health program. So I really I've seen these things happening in the schools, and the child-centered approach has forced me to ask this question: how can we prevent it? Definitely, we need to train our teachers, but how do we really go right up to the students so that we can prevent this child sexual abuse to happen? How can we empower? I asked this question before also, that we need to start on somewhere to empowering them. It's just not sexuality education. It's something more than that, empowering them to say no, and how do they know that what is the thing they can be taught by the teachers and the schools itself so that it can be prevented. And then the second thing which I really want to say is, my medical people, I take sessions on all these issues, they really think the reporting of the case is far more important than making the child comfortable. Before we make report to the police, we should take care of a child-centered approach and make him comfortable first, make him integrated first, and reclaim his rights. before we go about what this. The third thing is the societal issues. I've been a director of AIDS Control Society also. Believe me, when I go to the sex workers area, I've spent my life over there. In the afternoon time, most of the time, it is the adolescents from schools which are visiting the sex workers areas. And the issue which they have told me is just the pressure to perform on the first night. That's why they are here. And I really call sex workers as a coaching institute. How are we going to change the societal mindset that this experimentation, this exploration of their body is still there, which happens in the schools? People explore each other's bodies, each other's sexual organs to get that experience. So are these issues which are still left to be answered by Dr. Shekhar? I met him recently also in one of the conferences, and I've been to him many times. So please answer this question. Thank you very much. And appreciation for all. Thank you.
Thank you, sir. Thank you.
Once again, Kavita, I'll give him one answer. Jaipal, sir.
Ji, sir.
If you look, I can send you a publication in Indian Pediatrics done 20 years ago, when the whole 25 years ago, where the whole district, 11,000 plus 2 children were covered under this program. And it can be done by not by doctors, but trained other girls. We do developmental therapists. So that has been published in Indian Pediatrics. I can actually send you a copy of that also. There is a method, systematic method to do it. Every week, the 12 girls, they go to the school, they cover different classes, one day, one school. Like that, you are covered all 320 schools. It doesn't take so much of effort. It is possible to do, but it doesn't mean the class cannot be at the level of Shekhar or something. But basic information can be given to the children, that they have a right to report. They can, talk about their reproductive problems, etc. Thank you.
If I may come in here, Dr. Jaipal, we have been sharing modules with you, and Dr. Shekhar's module right from 0 to 18 years. And they're wonderful modules, both in English and Hindi, and very, very doable, both in the community settings and also in the clinical settings. I have used them myself, and I'm sure you could carry these modules. All the links I have posted on the group. That was one. And as you said about reporting, definitely we are not going against the law. Reporting is essential. But as Dr. Shekhar was saying repeatedly, there are steps for reporting. Again, the document, I'm just repeating this again because you asked this question. It has been posted, and definitely the child is very, very central. Reporting goes, but we have to look after the child. The emotional health of the child actually takes precedence, as Dr. Shekhar has been telling again and again to us. So it is a thing which will go together. Now, you talked about how to change the society and, the exploration and the experimentation in the adolescent age group. Again, I'll refer you back to the modules on sexuality education, where I was telling even last time, the life skill approach, I mentioned the window approach. Again, very, very powerful approach. I've tried it clinically, also in the community setting. The adolescents have loved it in the school settings. So please, I would say that, everything is available. We just need to implement. So I hope that with your good office that you are enjoying at the international level and the national level, we will see some really hardcore changes at the ground level to, as Dr. Shekhar Seshadri always say, healthy, safe, happy and responsible sexual relationships, which all our adolescents would enjoy. Thank you so much for your very much fantastic words and your inclination to work for healthy sexuality. Thank you so much. Radharani, you had a question, please.
Yeah. Good evening, sir. Shekhar Seshadri, sir. It's very nice, informative session. I'm Radharani from Hyderabad, from Barossa Center, sir. After so many days, I'm talking to you. Might be you remember or not. You came to Barossa. You have given the training along with Sheila ma'am. Sir, this is a question related to POCSO cases. Sir, actually, we'll ask them any trauma below 18 years. What is a childhood trauma? I asked. But one question that we are facing here. So, any adoption, any pregnancy after that delivery, we used to give the adoption, the children below 18 years, 15, 16 years. So that is also will become one kind of trauma now, sir, for the in future, because they are not, of course, they below 18 years, we cannot keep the children with them. We have to give to, as per CWC order, we have to give to the adoption, we have to go to the government wherever the child care institutions, Shishu Vihar and etc. So that is also going to the one kind of trauma to the children. So how to handle such children, sir? That is my question actually.
Sir, please unmute yourself.
Yeah, first of all, the order to place a child for adoption for let's say an 18-year-old who's delivered a child and she got pregnant due to whatever reason is not within the jurisdiction of CWC. They would be overreaching their jurisdiction. If you look at the latest CARA rules, the whole adoption thing comes under the jurisdiction of the district magistrate. It doesn't come under the jurisdiction of CWC. So CWC can order for institutional placement and inspection and so on and so forth. So adoption doesn't come under the jurisdiction of CWC. And the second issue, and I've already alluded to this, which is that the agency and the right of the mother to make the choice and then to provide an ecosystem that allows her to basically be in contact with the child if she does not want to give up the child. I mean, if she doesn't want to keep the child and wants to give it up, that's a different issue. Then the due processes can go on, and that child's placement. So the placement of the child in a 0 to 6 institution is a CWC order. But for adoption to take place, that comes to district magistrate.
Yes, sir, that is fine. My question is that placement and adoption is a different department. But my question is that because children are not willing to give to hand over to the government, they are very much attached to them because they want to take care of their children. But because as they are 18 years, we cannot keep them children. So that is also will becoming a big trauma to the children.
Yes,
Because of their separating.
Of course it will, because you have a bond of blood and you have a bond of love for the child.
Because nowadays children are delivering 14 years children, 13 years, 15, from starting to 13 to 18 years it is happening.
Which is why I said you have to create an ecosystem. Just as mental health is a mother-baby unit, you have to create an ecosystem, a state-run ecosystem, where under supervised care, both the 16-year-old mother and the infant child are allowed to stay till the mother reaches the age of 18, and then she's free to make her choice.
So can we allow her to see the children, her child or baby boy or baby girl?
No, there is no law that prevents her from seeing it. Would be criminal and inhuman and cruel.
Can we allow her to see the baby?
Why not?
Regularly.
No, what is your point? I'm not able to follow. Why would you not allow her to? If she does not want to give up the child, and if she wants to be in contact with the child, advocacy means that you will ask for this 16-year-old and the child to be in a placement where they are together.
Acha, we have to keep the place where they can stay together.
Yeah. This is the standard, if two siblings are put up for adoption, the rule of the thumb is you do not separate them. You ask for them to be adopted together. You do not allow siblings to be adopted separately.
Okay, sir. Thank you, sir. May I request? Thank you. Thank you, sir.
Thank you, Radharani. Thank you so much. So it's in fact a very emotional and overwhelming moment for me to say goodbye to all of you. It has been such a fascinating and enriching experience to be with all of you for the past 3 months. I must just give me a few minutes to thank everybody who really made this possible. It all started with Kavita approaching me early this year. And thank you, Kavita, so much. Words are not sufficient to actually express gratitude and appreciate the sheer strength of determination and grit that you have, and backed by Shilpa and the whole team of AHA Chhattisgarh. I can just say that IAP is in safe hands. And we are so proud of each one of you at AHA Chhattisgarh. And coming to the seniors, Dr. Pukhraj Bafna, Dr. Datke sir, your blessings, and each and every member of IAP Chhattisgarh, thank you so much for supporting us totally in toto. And every person, we talk about mental health of adolescents, but I think we should be talking a little bit about our self-care and mental health also. And I have these people whom I call Mehu Na, they are those kind of people, and everybody should have people like these in their lives. So the first Mehu Na person for me is my teacher, Dr. MKC Nair sir, who said, go for it. And we shall see how many people come to attend adolescent counseling. Pediatricians interested in counseling. I was asking sir said, go for it. And I had his full support. Dr. Shekhar Seshadri, Mehu Na again, I was with a problem, life skills, and I was asking him to take, and I was asking Samvad to take. They said, you go ahead, you take our PPT, and Mehu Na. Then we were in a lot of turmoil. We were not getting a platform to do this program. And I said, I'm going to drop this. And Dr. Gyanamurthy, I consider him as my brother, and he said, go for it. We shall make sure, talk to Dr. Jagdish Chinnappa. And I can say, Dr. Jagdish Chinnappa, though he had nothing at all to do with this program, to be very frank, but he said, I'm going to get you the platform. Don't worry at all. And I can say till date, he has been such a rock. You don't know him, but he has been such a rock between this program. And Kavita knows each time we have had a problem, that rock has been there with us. And we got to see him today, for which we are very much blessed. And last but not the least, I would just like to pay my heartfelt gratitude to the faculty who did such an amazing job. It was Shreyoshi Ghosh, Swati Ghate, Atul Kanekar, Newton Lewis, Amita Rao, Shubhada, Vinayak, Manoj Sharma, Chitra Dinkar, Paul Russell sir, Hima Bindu, and of course today, Dr. Shekhar Seshadri and Dr. MKC Nair. Each one of them is a sparkling star in the field. They are the people who are really working in the field, and they shared their expertise with us, for which we are very much indebted. So you can see we had a combination of pediatricians, psychologists, psychiatrists. What a wonderful multidisciplinary series this was. So hats off to each one of them. And thank you once again for being patient with my rather long note this time. Thank you once again. And to each one of you, 1,025 people on the group. Amazing, amazing. And your interest, your enthusiasm, your questions just kept us going again and again and on and on. Thank you once again to all the attendees. Thank you so much.
Congratulations, Dr. Kavita. Congratulations.
Thank you, sir. Thank you, ma'am. Thank you. Thanks
It's a
a lot.
milestone for CGHA.
Thank you, sir.
Dr.
Thank
Preeti,
you.
congratulations, Dr. Kavita, all of you. It was
Yeah,
so
Hima
amazing.
Bindu, ma'am, please.
Excellent.
Hima Bindu,
I
ma'am.
would like to, yeah.
Bake Namaskar.
Thank you.
Grand.
Thank you.
Yes, sir.
Thank you.
Thank you, sir. It was a very nice combination of seniors and, the way Dr. Preeti has managed the whole thing with under your leadership and guidance, and so many seniors were with us in this whole program. And Dr. Kavita, really, hats off to you. You have chosen to do a series, not just one episode. That's really amazing. And of course, it was so interesting that all of them joined, and they were, I think, still wanting. Let us see how we can continue this. And I'm really looking forward for all of your support ahead in the next.
Hima Bindu, madam, you have only 365 days in a year.
Yes, sir.
Plan it now.
I've started thinking from now only.
Yeah.
Yeah.
365
nice
days will go
I take
away
it.
like this.
I'm ready. Yes, sir. I'm ready to take over the charge and responsibility, sir. Thank you.
heard my
And I'll be in
suggestion?
contact with all
We
of
can
you.
have an official certificate program
Yes,
of academy. Think of that.
Sir, you please take my
Yes, sir.
suggestion. Start sport for course, online course for we people. who have missed your classes.
Only academic can do. Individually, I may not be. I won't.
It
I
is
can.
academic courses,
What
online
sir is telling?
courses.
I can do the other
No, what
supporting.
sir is telling is under AHA, that's what sir is suggesting.
Yeah,
Under
yeah.
AHA,
Yes.
sir will always be with us.
I'll
Sir
be
will
there.
always be with us under AHA. That's what sir is
AHA.
indicating.
Yeah.
Okay. No, sir, I was talking about the course also. I requested, sir, जो आप सबने किया, हमने miss किया, we should also get the opportunity to do that. If at all, sir can arrange course for us.
No, I think it's still
Online
there.
course.
No? I think it is still there in CDC. Child Adolescent Family Counseling. It is there.
Online course.
Not online. Online नहीं होगा.
Sir, online कुछ कीजिए ना हमारे लिए.
नहीं. No. There has to be at least 1 week contact program. You can't have a.
1 week we can like. It's
Yeah, that
okay.
is so plan it.
That is okay.
Himabindu will plan. She will consult me. We can do it. We can do it next week.
Sure,
I mean,
sir.
if this is successful, we can do a even bigger one.
Yes,
definitely, sir.
Kavita will do something. I
Yes,
will something. We'll do something.
Yes,
Yeah.
yes. So thank you, everyone. Actually, the success of this program, the entire credit goes to सबसे पहले तो MKC sir. So this moment is really emotional for me also. For last for so many Sundays, it became ritual. So I'm going to miss you all. So let me now conclude the session officially. So thanks a lot to each and everyone present here today as part and witness of the success of this entire series. Actually, 9 months back when I hold the responsibility of this post of chairperson of CG, I had no idea what and how to do. Just a good intention to do something different and better. As adolescent medicine is a budding branch and we all are learners with exceptionally few people who are the masters. So just a thought all of a sudden while I was at my OPD that created in my mind, and why not to learn from the masters. But I had no idea how to give the shape to this, my thought, and how it's going to take the reality. So I just called up Preeti ma'am. So, and then the things kept on happening. So I had really no idea, but जब कदम बढ़ाया तो लोग मिलते गए, कारवां बनता गया, and then rest you all are part and witness of this journey. And my respected seniors kept me guiding and motivating, and together we all walked through this entire enlightening journey of wisdom. So today I would like to pay my personal gratitude to each and everyone who has been the part of this success. So firstly, my deepest thanks goes to our guiding lights, Dr. MKC Nair sir and Dr. Preeti Galgali madam, whose wisdom has steered us throughout this series. MKC sir has not missed even a single episode, so I'm really, really grateful to you. So thank you, sir and ma'am. Your unwavering passion for adolescent health has brought this initiative to life. A heartfelt appreciation also extends to CIAP, CAHA, and CGAP office bearers. Your constant support and commitment have been invaluable, helping us explore vital facets of adolescent counseling and empowering us to better serve this crucial age group. We are incredibly fortunate to have had the presence of remarkable guests of honor and chairpersons who have lent their wisdom and stature to each session, and allow me to extend my sincerest thanks to Dr. Vasant Khalatkar, Dr. Kiran Makhija, Dr. Upen Kunjwarekar sir, Dr. Yogesh Parikh, Dr. Atanu Badra, Dr. Ajay Srivastava, Dr. Geeta Patil madam, Dr. Prakash Veer Arya sir, Dr. R.K. Pardal, Dr. A.T. Dapke sir, Dr. Sneha madam, Dr. Rajesh Agrawal, Dr. K.P. Sarabhai, Dr. Deoras, Dr. G. Malini, Dr. G.V. Basav Raja sir, Dr. Omkar Khandwal. Thank you everyone for your valuable contributions. Each of the speakers has enumerated critical aspects of adolescent counseling, and we are immensely thankful to all of them. Dr. MKC sir, Dr. Preeti madam, Dr. Shiroshi Ghosh, Dr. Swati Ghate, Dr. Atul Kanikar, Dr. Newton Lewis, Dr. Amita Rao, Dr. Shubhada, Dr. Vinay Kopade, Dr. Manoj Sharma, Dr. Chitra Dinakar, Dr. Paul Russell, Dr. Himabindu ma'am, and Dr. Shekhar Seshadri, and many others who have shared their expertise and insights over the course of this session. Your knowledge has truly shaped our understanding and approach to this vital topic. I extend my gratitude to the chairpersons who have so expertly moderated every session, ensuring a smooth flow of discussions. Dr. Geeta Patil, Dr. Pukhraj Bhafna, Dr. Madhushri Deshpande, Dr. Ashok Mehta, Dr. Amar Singh Thakur, Dr. Ashwini Agrawal, Dr. Nilay Mojarkar, Dr. Prankur Pandey, Dr. Sharja Fuljale, Dr. Raghaven Singh, Dr. B.B. Agrawal, Dr. Shekhar Seshadri, Dr. Payal Arora, Dr. A.P. Sawan, Dr. Arun Agarwala, Dr. Akash Lalwani, Dr. Sanjay Agrawal, Dr. Namita Srivastav, Dr. Harish Nayak, and Dr. Pooja Dhuppad. We are thankful to all of you. We are also grateful to Juventus, Centur, and Mayor for your steadfast partnership and sponsorship, helping us deliver this series with great success. Lastly, thanks to our participants, you have been the heartbeat of this series. Your engagement, curiosity, and commitment to learning have driven our every session for its success. And we hope this series has left you empowered and enlightened. As we close this chapter, left us take the sessions. We have learned the wisdom we have gained and applied them in a to better the lives of adolescents under our care. So let us continue the momentum forward and continue to make a difference with the lines, because the life was really a roller coaster ride. This entire series was. So I would finally love to say that हौसला अगर कुछ कर गुजरने का तो मंजिल मिल ही जाएगी. रास्ते मुश्किल हो सकते हैं, पर चाहोगे तो हवाओं के रुख भी बदल सकते हैं. So let us together make the difference. And thank you each and everyone. You have been the part of the success of this entire series. And I would love to see you all live at Nasik. Thank you. Thanks again. MKC sir, Preeti madam, I have no words to say thanks to both of you. The entire success actually belongs to you only. वो कहते हैं कि करते हो तुम कन्हैया, नाम मेरा हो रहा है, तो किया आप दोनों ने और नाम मेरा हो गया. So thank you each, thank you both of you. Thank you.
Same pinch, Kavita. I can only say that. Sir is our guru. He'll forever remain a guru. So for sir, I have no words. Like
so. MKC sir, I'm going to miss you on every Sunday.
We are all blessed. We'll not leave sir. We'll involve him, engage him. And
yeah,
ma'am.
In your tenure, I think we can have more sessions with sir.
Yeah.
He is like Gita, जो है Bhagavad Gita of this adolescence.
And I
so
always
you have to
take
learn a lot from him.
Yeah, we always take his guidance, and I'm sure you'll have many more sessions with him in future.
I would like to share my one secret. When I was just beginner in my practice, जब मैं रायपुर में नया आई थी, तब MKC सर का कोई टॉक हुआ था, फैमिली काउंसलिंग पर ही शायद हुआ था. At that very moment I became your fan. और उसके बाद I always just kept on thinking कि कैसे आपसे मिलना होगा, जो मेरे नसीब में कभी नहीं हुआ. So this was the platform when I could meet you again after so many years. So thank you.
Thank you.
Thank you.
Thank you all. Good night.
You can't sleep today, sir.
Thank
you. You are so fans.
I'm one of the biggest fan of MKC sir. Even MKC sir don't know how much biggest fan I am. So
bye-bye.
Bye.
Bye-bye.
Bye. Thank you. Bye-bye. Have a good Sunday.
Sorry, my throat was bad today, but
Sunday is over.
Chaliye, okay, sir. Bye-bye.
Bye.
Take rest, Kavita, now. Take rest. Bye-bye.
Thank you, everyone. Thank you, madam.
Thank you, sir. Thank you.